आना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी। आइए जानते हैं डिहाइड्रेशन के लक्षण क्या है। चक्कर आना, मुंह सूखना, थकान और सर दर्द, बार बार प्यास लगना, ड्राई स्किन होना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 आइए जानते हैं डिहाइड्रेशन के लक्षण क्या है। चक्कर आना, मुंह सूखना, थकान और सर दर्द, बार बार प्यास लगना, ड्राई स्किन होना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी।
Hello, welcome to 12th Respiratory Conference.
आइए जानते हैं डिहाइड्रेशन के लक्षण क्या है। चक्कर आना, मुंह सूखना, थकान और सर दर्द, बार बार प्यास लगना, ड्राई स्किन होना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी। आइए जानते हैं डिहाइड्रेशन के लक्षण क्या है। चक्कर आना, मुंह सूखना, थकान और सर दर्द, बार बार प्यास लगना, ड्राई स्किन होना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी। आइए जानते हैं गर्मी। खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी। आइए जानते हैं डिहाइड्रेशन के लक्षण क्या है। चक्कर आना, मुंह सूखना, थकान और सर दर्द, बार बार प्यास लगना, ड्राई स्किन होना। तो इस गर्मी खुद का ख्याल रखें, खुद को हाइड्रेटेड रखें। ज्यादा जानकारी के लिए अभी कॉल करें या विजिट करें ब्रेथ इजी हॉस्पिटल, 80 लंका रोड, वाराणसी। आगे जाते हैं patient condition क्या है और क्या जानकारी के लिए
हेलो। इसका ऑडियो नहीं है। ऑडियो देखो।
Recording in progress.
Good evening, everyone. On the behalf of Respiratory Conclave Conference entire team, I, Abhishek, welcomes you all. It's a privilege to have national and international fames today with us at Respiratory Conclave Conference 2024. I also would like to thank from all of us to the Chairman of Respiratory Conclave Conference, Dr. Rajin Prasad sir, and Organizing Secretary, Dr. S.K. Pathak sir, who has done a tremendous and outstanding work in the foundation of Respiratory Conclave Conference since 2014. A special gratitude to our guest faculties of Respiratory Conclave Conference since 2014 who have given their valuable time and knowledge. I may not able to speak all the guest faculties name because of short of time because it's starting from 2014, but I would like to definitely mention few of the names like Dr. Rajendra Prasad sir, Director and Head of Eras Medical College, Padma Shri Dr. Randeep Guleria sir, former Director AIMS, Dr. S.K. Katiyar sir, HOD TB and Chest Department, GSVM Kanpur, Dr. J.C. Suri sir, Safdarjung Hospital, Delhi, Dr. P.C. Katoria sir, Director, Allergy Care Center, Delhi, Dr. Prabhu Desai sir, Senior Pulmonology, Lilavati Hospital, Dr. Suryakant Tripathi sir, HOD TB and Chest Department, KGMC Lucknow, and many more national and international speakers. For that, I would like to show a small video of Respiratory Conclave Conference timeline. ये वाला इसको करो। A big round of applause for our guest faculties. Since 2014, we have added like almost more than 35 speakers, national and international fames. एंड थैंक यू फॉर अवेलेबल टाइम। आगे सर। नगरी हो काशी की और जहां स्वयं श्री काशी विश्वनाथ का वास हो, ऐसे में उनके उद्घोष के बगैर सब कुछ अधूरा रह जाता है। इसलिए कार्यक्रम की शुरुआत हम लोग आगे करते हैं भगवान श्री काशी विश्वनाथ के उद्घोष से। हर हर महादेव। नाउ आई वुड लाइक टू हैंड ओवर द सेशन टू डॉक्टर एस के पाठक सर। सर।
Good evening, everyone, and our respected faculties. It gives me a great pleasure to extend the warm welcome to on behalf of Respiratory Conclave Conference 2024, and to say the how grateful to word of the fame renowned faculties present today. Our two faculties are missing, Dr. Rajadhans and Dr. Deepak Talwar, but our special faculties present here. Our chief guest, Dr. S.S. Sankhwar, sir, please come and rise. Please. Sir, Dr. Rajendra Prasad, sir, please. Sir, Dr. Sandeep Chaudhary, sir, Talia. Dr. Vivek Nagia, sir, please. Two faculty just entered here. Dr. Prasad Chathana and Dr. Prabhu Desai, sir. Thank you for welcome greetings from our Respiratory Conclave Conference 2024, sir. Just we all are grateful to you, sir. Everyone present here as a faculties. It's gratifying to note that agenda of the scientific session covers the wide range of the basic and advanced respiratory diseases and diagnosis and management. Not taking the much time, I would like to open the session for press conference for our faculties present here. Media persons requested to ask if you have any, आपके पास कोई सवाल जवाब, चूंकि सांस की बीमारियां बढ़ रही है लगातार, तो हम अपने एक्सपर्ट के साथ कुछ इस पर डिस्कशन करेंगे और कुछ एजेंडे के साथ हम लोग डिस्कशन करेंगे। यहाँ पर एजेंडा जो है आप अपने हिसाब से भी खोल सकते हैं, यहाँ पर हमारे फैकल्टीज हैं वो इस पर जवाब देंगे। माइक 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 ऑडियंस माइक।
अस्थमा और दमा के अंतर को कैसे पहचानें और इसके इलाज में क्या अंतर है?
सर राजेंद्र प्रसाद सर प्लीज आंसर दिस।
देखिए, आपका सवाल तो बहुत अच्छा है, लेकिन अस्थमा का जो वर्ड है वो हमारे देश में दमा से ही उसको इक्वेट किया जाता है। और अस्थमा ऐसा है, अस्थमा में लोगों की सांस फूलती है, दमा में भी लोगों की बीमारी तो एक है, लेकिन लोगों में भ्रांतियां बहुत हैं। बहुत लोग सोचते हैं कि जैसे एक कहावत है ना, दमा दम के संग जाता है, तो वो कहावत गलत नहीं है, लेकिन ये है बीमारी अब ऐसी है आज के जमाने में कि टोटली ये अंडर कंट्रोल रखी जा सकती है, बशर्ते आपका निदान सही हो जाए, बशर्ते आप जो भी दवाएं डॉक्टर लोग बताते हैं उसको कायदे से लिया जाए।
दोनों की शुरुआती पहचान क्या है?
जैसे मैं बस दोनों के शुरुआती में सांस का अटैक पड़ता है, खासकर जब मौसम बदलता है तो बढ़ जाता है, और ऐसी बीमारी मोस्टली चूंकि मतलब एलर्जिक होती है तो फैमिलीज में भी, उनके माता पिता में भी किन्हीं में से ये बीमारी पाए जाने की संभावना रहती है। लेकिन जो सबसे खुशी की बात है, आज हम अगर 2024 में बात कर रहे हैं तो अब इतनी अच्छी दवाएं आ गई हैं कि आदमी अपना बिल्कुल नॉर्मल जीवन बिता सकता है, डरने की आवश्यकता नहीं है। और जो मैं तो ये कहता हूँ, वो जो कहावत थी, वो ठीक है, बीमारी को जैसे मैं अक्सर अब मैं ट्यूबरकुलोसिस से इक्वेट करता हूँ। हमें पता है कि ट्यूबरकुलोसिस अगर 6 महीने का इलाज कर ले तो शायद हम भी नहीं बता पाएंगे उसको बाद में उसको टीबी हुई। लेकिन ये दमा की बीमारी थोड़ी चलती है, रहती है, लेकिन परेशान नहीं करती है, बशर्ते दवा को कायदे से लिया जाए। भ्रांति क्या है, जैसे तकलीफ दूर होती है तो दवाई लोग छोड़ देते हैं और उसमें फिर परेशान होते हैं, अस्पताल में भी जाते हैं, मृत्यु भी होती है। तो सब तरह की चीजें देखी गई हैं, लेकिन बहुत अच्छी बात है कि दवा ठीक से करिए तो बिल्कुल आप जीवन बिता सकते
गुड इवनिंग डॉक्टर साहब। गुड इवनिंग डॉक्टर साहब। आई एम रीना फ्रॉम क्लाउंटाइन्स प्रेस इन वाराणसी। मेरा क्वेश्चन है आपसे कि ये टीबी क्या है, ये खतरनाक टीबी क्या होता है और इसे हम कैसे पहचानें?
टीबी एक प्रकार का इन्फेक्शन होता है जो एक ह्यूमन बीइंग से दूसरे ह्यूमन बीइंग को स्प्रेड करता है। इसका जो कॉजेटिव ऑर्गेनिज्म है उसको माइकोबैक्टीरियम कहते हैं। माइकोबैक्टीरियम भी कई प्रकार के होते हैं। टीबी का प्रॉब्लम क्या है कि अब टीबी भी कई प्रकार की होने लग गई है, जैसे कि साधारण टीबी है जो साधारण दवाइयों से रेस्पॉन्ड करती है, फिर ड्रग रेजिस्टेंट टीबी है। ड्रग रेजिस्टेंट टीबी में भी पॉली ड्रग रेजिस्टेंस है, मल्टी ड्रग रेजिस्टेंस है, एक्सडीआर है। सो जैसे जैसे टीबी के रेजिस्टेंस पैटर्न बढ़ता जाता है वो बीमारी और ज्यादा सीरियस और डिफिकल्ट टू मैनेज होती जाती है। जो ऑर्डिनरी टीबी होती है उसका अगर एक पेशेंट स्टैंडर्ड कोर्स ऑफ ट्रीटमेंट लेता है जो 6 महीने का अब रेकमेंडेड है डब्ल्यूएचओ का भी, इंडियन गवर्नमेंट का भी, तो उससे काफी हद तक बीमारी मतलब काफी हद तक प्रोबेबिलिटी होती है कि बीमारी बिल्कुल जड़ से खत्म हो जाएगी। टीबी और एस्मा में फर्क ये होता है या कोई भी और क्रॉनिक डिजीज में फर्क ये होता है कि टीबी एक इन्फेक्शन है जिसकी हमें संभावना है कि पूरी 100% खत्म हो जाएगी अगर आपने ट्रीटमेंट रेगुलरली लिया है तो, और बैक्टीरिया जो है सेंसिटिव है तो। बल्कि एस्मा, सीओपीडी जैसी बीमारियां जो होती हैं वो क्रॉनिक बीमारियां होती हैं जिनको अंडर कंट्रोल रखना पड़ता है कंटिन्यूअसली। रेगुलर ट्रीटमेंट लेना जरूरी होता है, जैसे डायबिटीज है, ब्लड प्रेशर है, हार्ट की बीमारियां हैं, उनके लिए रेगुलर ट्रीटमेंट चलता है। ऐसे ही एस्मा, सीओपीडी, दमा, इन सब के लिए रेगुलर ट्रीटमेंट लेना बहुत जरूरी होता है।
डॉक्टर साहब, छुपी हुई टीबी की जानकारी हम आधुनिक तरीके से कैसे लें?
छुपी हुई टीबी में भी दो प्रकार की बीमारियां हो सकती हैं, जैसे आपने बोला। एक लेटेंट टीबी होती है, जब हमारे शरीर के अंदर बैक्टीरिया एंटर करता है तो हमारी जो शरीर की इम्यूनिटी होती है उस बैक्टीरिया को उस जगह पे सप्रेस कर देती है, उसको रोक देती है ताकि आगे ना पनपे। उसको लेटेंट टीबी कहा जाता है। पर जब ये अपनी किसी भी कारण की वजह से आपकी इम्यूनिटी लो होती है या जो बैक्टीरिया है वो बहुत ज्यादा पावरफुल होता है तो उस स्थिति में इन्फेक्शन पनपने लगती है फिर। सो लेटेंट टीबी को पहचानने के लिए तो टेस्ट आते हैं, स्किन के टेस्ट होते हैं, ब्लड के टेस्ट होते हैं जिनसे पता लग सकता है। और टीबी जो बीमारी बन गई है उसको पहचानने के लिए काफी टेस्ट है, अगेन एक्सरे है, सीटी स्कैन है, बलगम की जांचें हैं, हम अंदर से दूरबीन की जांच करते हैं, ब्रोंकोस्कोपी करते हैं। अगर कोई ग्लैंड इन्वॉल्वमेंट है तो उसमें ईबस करके उसमें से मटेरियल निकाल सकते हैं। आपने बोला कि आधुनिक तरीके क्या हैं, आधुनिक तरीकों में अब बहुत तरीके हो गए हैं। अब हम लोग ये प्रचार करते हैं कि टीबी का जो ट्रीटमेंट है वो सिर्फ लक्षण के बेसिस पे या सिर्फ एक एक्सरे की पिक्चर के बेसिस पे नहीं शुरू करना चाहिए। हमें उसकी तय तक जाना चाहिए, पहचानना चाहिए कि एक के टीबी है कि नहीं है, कंफर्म करके उसके बाद टीबी किस प्रकार की है, साधारण टीबी है, ड्रग रेजिस्टेंट टीबी है, और उसके हिसाब से फिर इलाज करना चाहिए।
सर, एआई का जो रोल है ये मेडिसिन में और हेल्थ केयर में, इसमें बहुत पोटेंशियल है। अभी शुरुआत हुई है। एआई का अभी जो हम रोल यूज करते हैं वो है डायग्नोस्टिक्स में। लंग्स के ऊपर सीटी जब इमेजिंग किया जाता है, सीटी स्कैन किया जाता है, एक्सरे किया जाता है। अभी सीटी स्कैन के अंदर जो फाइंडिंग्स है उनको अच्छी तरह से कैसे प्रिडिक्ट किया जाए। जो छोटे छोटे नोड्यूल्स होते हैं, तो वो जो नोड्यूल्स का कैंसर के है कि कैंसर के नहीं है, वो जानकारी में एआई हेल्प कर सकती है। एआई हेल्थ केयर में अभी एक बहुत नेसेंट स्थिति में है। एआई को अभी और बहुत डेवलप होना है। बट इस ये बहुत इंटरेस्टिंग एरिया है। यहाँ पे बहुत डेटा कलेक्शन चल रहा है और आगे जाके आई थिंक एआई के वजह से हम जो बीमारियां हैं उन्हें शायद जल्दी से डायग्नोस कर पाए और बहुत प्रिसाइज वे में डायग्नोस कर पाए और इसकी जो ट्रीटमेंट की जो प्रिसिशन है उसमें भी इम्प्रूवमेंट की आकांक्षा है।
बहुत अच्छा सवाल किया है। जैसे हम लोग अभी डॉक्टर नांगिया जी ने टीबी के बारे में थूक का तपास एक्सरे बोले, वैसे लंग की फिजियोलॉजी, लंग का काम कैसा चल रहा है ये समझना एक अलग है। जैसा एनाटॉमी समझ में आती है वैसे फिजियोलॉजी समझ में आना भी उतना ही इम्पोर्टेंट रहता है, जिससे हम पता लगा सकते हैं कि लंग की बीमारी कौन से कारण हुई है। कि विंड पाइप में सूजन है उसके कारण हुई है, क्या लंग का जो पैरेंकाइमा है जिधर ऑक्सीजन और खून में ऑक्सीजन और कार्बन डाइऑक्साइड की लेन देन होती है ये जगह पे हुई है, क्या ये जो टेस्ट जो हम करते हैं क्या उसका हमारा वॉकिंग से या एक्सरसाइज से क्या मतलब होता है। सो ये जो फिजियोलॉजी का जो अंडरस्टैंडिंग है वो हम लंग फंक्शन टेस्ट से करते हैं। जितना एक्सरे इंपॉर्टेंट है उसका ही अधिक जानकारी हम अस्थमा और सीओपीडी के बारे में लंग फंक्शन टेस्ट से करते हैं। कभी कभी लंग फंक्शन टेस्ट ही वो बीमारी की जानकारी देती है। जैसा आपने पूछा दम के कारण, हार्ट के कारण भी दम लग सकता है, अस्थमा के कारण भी दम लग सकता है, खून कम होने के कारण भी दम लग सकता है। तो ये जो दम है उसमें वो अस्थमा है, लंग के कारण दम है क्या और दूसरे कारण दम है, तो वो समझने के लिए ये लंग फंक्शन टेस्ट बहुत इंपॉर्टेंट है।
वैसे भी we have seen and I have seen some news reports. इसका जो आफ्टर इन्फेक्शन लंग पर जो वैक्सीनेशन जिन्होंने लिया इसमें व्हाट यू से उसका क्या कोई एक्टिव इफेक्ट पड़ा है क्योंकि लंग्स की जो
पर
डेंजर भी हुई है।
कोरोना की जो बीमारी और कोरोना वैक्सीन के कारण होने वाली बीमारी, इसमें काफी वादंग है और इसमें बहुत डिस्प्यूट्स है, मगर एज ए डॉक्टर आई कैन टेल यू दैट कोरोना वैक्सीन हैज हेल्प थाउजेंड्स नहीं करोड्स ऑफ पीपल टू गेट अवे और गेट द प्रोटेक्शन फ्रॉम सीरियस कोरोना इन्फेक्शन। और उसका फायदा ज्यादा है, नुकसान मैं बोलूंगा कि नाक है नहीं, ना से नाक बराबर है। और जो भी कुछ हम सुनते हैं सब वो व्हाट्सएप यूनिवर्सिटी से सुनते हैं, वो सच नहीं रहता है। और वैक्सीन वापस लेने का जो रीजन है वो आई डोंट थिंक इट इज बिकॉज ऑफ एनी कॉम्प्लिकेशन दैट हैपेंड, दैट्स व्हाई इट्स बी नॉट रीड इट नाउ। सो प्रोबेबली दैट मे बी वन ऑफ द रीजन, वो रीजन भी हो सकता है। मगर हमको जो कोरोना के बारे में जो कंट्रोवर्सी है उसमें मुझे नहीं लगता है इतना तथ्य होना चाहिए, हम उसके बारे में ज्यादा डिस्कस करने में मतलब नहीं है, ऐसा मुझे लगता है।
What you say from those lung diseases and asthma and dama and all this क्योंकि वो इट इज अवेलेबल क्योंकि कंडीशन लगता है ट्रैफिक का तो वहाँ पे बहुत ज्यादा पोल्यूशन होता है पेट्रोल का इसका उसका वैसे भी सिटिंग पे वैसे भी पोल्यूटेड हो चुकी का तो हाउ टू प्रिवेंट अवर सेल्फ एंड टू परफेक्ट अवर हेल्थ डे टू डे लाइफ।
वहाँ का मीडिया बहुत स्मार्ट है।
जहाँ तक पोल्यूशन की बात है, दैट्स फैक्ट दैट कि वी ऑल हैव टू लर्न दिस। हमें सबको सीखना है कि हमें कहीं ना कहीं इस पोल्यूशन में कम करने के लिए जो हमें भी मदद करना पड़ेगा, सरकार को साथ में पेड़ को लगाना, हमें भी सहयोग करना पड़ेगा आगे। और पोल्यूशन की बात है तो कहीं ना कहीं हमारा भी बहुत हाथ होता है। सरकार तो अपने तरफ से हर जगह करती है, लेकिन जहाँ अब एक अवेयरनेस ड्राइव हमें अपने में भी चलाना है और एक अवेयरनेस ड्राइव पब्लिक से भी होना चाहिए इस बात से के लिए कि हमें कौन-कौन चीज़ें हैं जो क्रिएट कर रही हैं और उसके लिए क्या-क्या स्थान है जहाँ पे हम जाके इसको अपनी जानकारी ले सकते हैं या इससे बचाव। तो एक ड्राइव एक सिंगल एक यूनिट्स के तरफ से नहीं हो सकता है। एक जनरल हम सब मिलके पॉल्यूशन से रिलेट करके उसके क्या आउटकम्स है उसको जानना, उसको सहयोग करना।
सर सामने देखो, सर सामने देखो।
हाउ प्रिवेंट अवरसेल्फ?
अभी तो ऐसा कोई कोरोना का माहौल नहीं चल रहा है। हाँ, पोल्यूशन की आप अगर सेंसिटिव हैं, अच्छे हैं, तो आपको अगर लग रहा है कि वहाँ पे पोल्यूशन एरिया है, इस आपको डिस्टर्ब हो रहा है, आपको तो आप मास्क पहने, उसमें कोई नुकसान नहीं है। वो तो आपको बेहतर के लिए है, वैसे भी आपके बेहतर के लिए है।
डॉक्टर साहब, ये आईएलडी बीमारी क्या है?
आईएलडी की बीमारी के बारे में चर्चा हम करेंगे। एक्चुअली आईएलडी एक तरह से सांस की बीमारी है, और ये पहले भी थी, अब भी है, लेकिन अभी रिसेंटली इस पर काफी सारा रिसर्च हुआ है। और इस रिसर्च में ये देखा गया है कि खासकर कई सारे पॉल्यूशन इफेक्ट के कारण भी लंग्स में कुछ दिक्कतें आती हैं, जिसको हम लोग कहते हैं लंग फाइब्रोसिस। और लंग की फाइब्रोसिस कई सारे फैक्टर होते हैं, जिसमें मेडिसिन से भी फाइब्रोसिस हो जाती है, कुछ डिजीजेज होती है उसके कारण होती हैं, और कुछ इन्फेक्शियस डिजीज भी होती है उसके कारण भी हो सकती हैं। तो एक तरह से ये बीमारी सांस फूलने की बीमारी है, दमा से मिलती जुलती बीमारी है, लेकिन दमा नहीं है। इसमें लंग्स का जो पीएफटी अगर हम करते हैं तो रिस्ट्रिक्टिव पैटर्न होता है, जिसमें मूवमेंट लंग्स का बहुत कम हो जाता है, और इसका इलाज न किया जाए तो सांस लगातार फूलती रहती है और आगे ऑक्सीजन जैसी जरूरत पड़ने लगती है। तो आईएलडी की बीमारी के लिए जो डायग्नोसिस बनानी होती है, स्पेशली हम लोग लंग फंक्शन टेस्ट से और एक एचआरसीटी थोरेक्स से, ये सबसे एक बेसिक डायग्नोसिस बना लेते हैं। कभी कभी जरूरत पड़ती है तो हम लोग ब्रोंकोस्कोपी करते हैं। कई सारे और टेक्निक है जिसके द्वारा पता कर सकते हैं कि आईएलडी बीमारी या लंग फाइब्रोसिस बीमारी में क्या स्थिति है और कैसे है, कैसे हम पहचाने। इसकी मेडिसिन एक्चुअली एक तरह से इसको लंग्स का गठिया भी बोला जाता है, अर्थराइटिस भी बोला जाता है, और कई सारे ऐसी डिजीज होती हैं उसके कारण ये प्रॉब्लम लंग्स में सबमिट भी हो जाती है। तो इस बीमारी का पता करना बहुत ही मुश्किल होता है, खासकर जनरल प्रैक्टिशनर के लिए, लेकिन हमारे जो एक्सपर्ट है चेस्ट स्पेशलिस्ट, वो थोड़ा जल्दी पता कर लेते हैं अपेक्षाकृत जनरल प्रैक्टिस। ये दमा से ज्यादा खतरनाक, दमा में तो आप दवा लेते हैं तो बिल्कुल ठीक हो जाते हैं, लेकिन इसमें दवा लेने पर आपका वो नॉर्मल कंडीशन होना बहुत मुश्किल हो जाता है। तो इसमें दवा रेगुलर लेनी होती है, और लंग्स की एक्सरसाइज, कुछ मेडिसिन होती है जो फाइब्रिटी को रोकने के लिए होती है, लेकिन ये रिटर्न बैक नॉर्मल में होने का चांस बहुत कम रहता है। सर, डॉक्टर पीसी कोथरिया सर। सर आइए आइए सर, आइए सर, आप एक्सपर्ट।
देखिए, हवा में कई ऐसे कण हैं जिसको कि हम एलर्जी कारक पदार्थ बोलते हैं। इन एलर्जी कारक पदार्थ जब हमारे नाक के जरिए हमारे लंग्स में जाते हैं, वो एक सांस की नली को कुरेदना शुरू करते हैं। जैसे एक दीमक होता है, दीवार को खाता है, वैसे ही ये एलर्जी कारक पदार्थ हमारी सांस की नली को कुरेदते हैं, और धीरे धीरे करके हमारी सांस की नली में सूजन पैदा हो जाती है, और वो सूजन बाद में हमारे दमा में परिवर्तित हो जाती है। इसको हम एलर्जिक अस्थमा करते हैं। जैसे कि आपने पॉल्यूशन के बारे में क्वेश्चन पूछा, पॉल्यूटेंट और एलर्जी कारक पदार्थ ये दोनों सगे भाई हैं। मान लीजिए कि एक इंसान है जो सिर्फ कोल माइनर्स में काम करता है, उसको जीवन भर कुछ नहीं होता, लेकिन वही इंसान को अगर बचपन में ही सांस की प्रॉब्लम एलर्जी के कारण होती है, तो पहले ही दिन जब वो उसमें काम करेगा, उसी में उसको एलर्जिक और पॉल्यूटेंट मिल करके उसकी सांस की नली को खाना शुरू कर देंगे, और बाद में जैसे ही धीरे धीरे बड़ा होगा वो दमे में परिवर्तित हो जाएगा। इसको
डॉक्टर, एलर्जी अस्थमा एवं एलर्जी राइनाइटिस में इम्यूनोथेरेपी की कितनी इंपॉर्टेंस है?
इम्यूनोथेरेपी, एलर्जी का टेस्ट ब्लड के द्वारा किया जाता है, और ये स्किन के ऊपर कुछ एलर्जी कारक पदार्थ को हम टच करते हैं और प्रिक करके हम उसे पता लगते हैं कि हमारी सांस की नली में सूजन है नहीं। स्किन एक तरीके से हमारा लंग का एक मिरर है, एक शीशा है, जिसके जरिए हम टेस्ट करते हैं। ऐसे ही हर एलर्जी कारक पदार्थ जो हमारे नाक के जरिए, आंख के जरिए, मुंह के जरिए जो हमारे ब्लड में जाते हैं, तो वो हम ब्लड के द्वारा भी टेस्ट कर सकते हैं।
डॉक्टर, मैं रिपीट करती हूँ, एलर्जी अस्थमा एवं एलर्जी राइनाइटिस में इम्यूनोथेरेपी की क्या इंपॉर्टेंस है?
इम्यूनोथेरेपी एक तरीके से इटियोलॉजिकल ट्रीटमेंट है। मान लें कि हमने कारण को ढूंढ लिया कि एलर्जी है, अब जब तक कि हम उस इटियोलॉजिकल ट्रीटमेंट को ठीक नहीं करेंगे, तब तक एलर्जिक राइनाइटिस ठीक नहीं होगी। ये उस बीमारी का रेमिशन करती है, इसको हम क्लिनिकल रेमिशन कहते हैं। और दूसरा जब हम इम्यूनोथेरेपी देते हैं तो एलर्जिक राइनाइटिस के पेशेंट को दमा होने से बचाती है। जैसे ही हमें पता चलता है कि हमें एलर्जिक राइनाइटिस है, दवाइयों से उसका असर नहीं पड़ रहा, उसी समय हम जब इम्यूनोथेरेपी स्टार्ट करते हैं, हम उस बच्चों को, जो बच्चे बेचारे अभी छोटी साल 3 साल 5 साल 10 साल के अंदर दमे में परिवर्तित ना हो जाएं, उसके लिए इम्यूनोथेरेपी इज द ओनली एटियोलॉजिकल ट्रीटमेंट इन द वर्ल्ड।
थैंक यू सर। थैंक यू। हाँ सर, सर जस्ट
जी सर।
क्वेश्चन। एक सवाल माइक।
ये आप क्या कुछ
आपका क्या सवाल है सर? बराबर है।
एक बार जो वर्क करते हैं
नो
चाहते हैं अगर हम मॉर्निंग वॉक या इवनिंग वॉक करें।
यस, मॉर्निंग वॉक ये हमेशा अच्छा रहता है। सो के उठने के बाद सबसे पहली बात है, सन में जाएंगे आप मॉर्निंग में तो उससे बहुत ज्यादा फायदा होता है। और वॉक करने से आपकी फिजियोलॉजी अच्छी हो जाती है, एक्सरसाइज है वो। और मुझे लगता है आप जितना अच्छी तरह से ब्रिस्क वॉक कम से कम 40-45 मिनट्स तक कर सकते हैं, उसके लिए कुछ खर्चा नहीं है तो मरीज को और आदमियों को उससे ज्यादा बेनिफिट्स ही मिलते हैं। एक चीज हमेशा ध्यान में रखिए, अभी शहर में जो रहते हैं उनमें पोल्यूशन की लेवल मॉर्निंग में काफी ज्यादा रहती है, तो उसके कारण कभी कभी उनको सांस की बीमारियां भी लग सकती है। तो आपका जो शहर है उसमें एयर पोल्यूशन की क्वालिटी कैसी है मॉर्निंग में, उसका भी एक असर होता है। नहीं तो फिर काफी मरीजों को खांसी मॉर्निंग में आ जाती है। तो ये अगर ये सब समझ में आए तो हम कहेंगे कि मॉर्निंग वॉक इज बेनिफिशियल।
हमारे साथ हिंदुस्तान के रिपोर्टर हैं सवाल।
जी नमस्कार। मैं मुदस्सिर हूँ। मेरा सवाल, चूंकि आप सारे लोग यहाँ एक्सपर्ट बैठे हैं, एक सवाल आप लोगों से ये कि इस समय जैसे खर्राटा इस समय हर घर की एक समस्या हो गई है। खर्राटे से जो है इस समय मैं देख रहा हूँ ज्यादातर लोग इससे परेशान हैं। इसका समाधान और इसके कारण क्या है और क्या इसका अस्थायी इलाज भी है क्या? इसके बारे में अगर कोई एक्सपर्ट हो तो प्लीज बता दें
सर।
मैं खर्राटे से पहले अभी एक भाई साहब ने मॉर्निंग वॉक के बारे में पूछा, तो मैं 2 मिनट लूंगा उस पर कि देखिए जीवन शैली का बड़ा महत्व है। अगर आपकी जीवन शैली अच्छी है, और जीवन शैली में सिर्फ मॉर्निंग वॉक ही नहीं आता है, आपका विचार कैसा है, आपका आहार कैसा है, क्या हो रहा। मैं अक्सर कहता हूँ आज के जमाने में लोग डबल और ट्रिपल पर्सनालिटी रखते हैं, सोचते कुछ हैं, बोलते कुछ हैं, करते कुछ है। तो जीवन शैली का अपना एक बहुत बड़ा, काफी स्टडीज अब हो चुकी हैं, डाइट पे हो चुकी है, जीवन शैली पे हो चुकी है, और बड़ा क्लियर हो चुका है। अच्छा जीवन शैली रखेंगे तो आपकी लाइफ प्रोलॉन्ग होगी, आपकी क्वालिटी ऑफ लाइफ अच्छी होगी, इसमें कोई दो राय अब है ही नहीं। या हम ये कहें, जो हमारे जो बुजुर्ग लोग थे पुराने जमाने के, अब हम लोग भी धीरे धीरे बुजुर्ग ही हो रहे हैं लेकिन उस जमाने के लोग जो फॉलो करते थे वो मुझे तो लगता है बहुत ही साइंटिफिक था। अब जो है, आप जो स्लीप के बारे में आपने खर्राटे, देखिए गांव में अक्सर एक कहावत थी, हमारे बचपन में एक बहुत मोटा सा हलवाई था, तो वो इतना तेज खर्राटे लेता था कि 10-20 घरों में सुनाई पड़ता था। तो बचपन में हमारे पिताजी लोग कहते थे, देखो भाई उसको बड़ी अच्छी नींद आती है, बहुत तगड़ा खर्राटे लेता है। तो खर्राटे लेना एक परेशानी वाली चीज है। अगर किसी को तेज खर्राटे, आप ट्रेन में जाते हो, काफी लोग खर्राटे लेते हैं जब सोते हैं, इसको हम ऑब्स्ट्रक्टिव स्लीप एपनिया कहते हैं। इसमें खर्राटे आते हैं, रात को आप सोते हैं तो नींद आपकी डिस्टर्ब होती है, और जब खर्राटे लेते हैं तो एपनिया होता है, तो ऑक्सीजन लेवल कम होता है, तो वो आपके हार्ट पे, ब्रेन पे, शरीर के लगभग लगभग हर हिस्से में असर डालता है। और जहां तक इसके निदान की बात है, आजकल बहुत आसान हो गया है निदान। इसकी एक स्लीप टेस्ट जिसे हम कहते हैं, वो स्लीप टेस्ट से पता लग जाता है कि वो खर्राटे हैं तो कितना नुकसान करेगा, कैसे है, उसका उसका ट्रीटमेंट भी अब हो जाता है। तो कोई घबराने की बात नहीं है, लेकिन बहुत कॉमन बीमारी हो गई है और काफी। लेकिन सबसे बड़ा दुर्भाग्य क्या है, अभी भी लोगों में अज्ञानता बहुत है।
थैंक यू सर।
कुछ ही लोगों से तो जवाब ही नहीं देते। आदमी तो बोलेगा नहीं। अब अक्सर हम अपने पीजी को पढ़ाते हैं, हम कहते हैं आदमी नहीं बताएगा, उसकी पत्नी से पूछो कि कराटे लेता है कि नहीं लेता है। तो वो बेटर हाफ से पूछ करके काफी लग के, लेकिन अब बहुत आसान हो गया पता लगाना हर चीज।
थैंक यू सर। अभी प्रेस कॉन्फ्रेंस में बहुत सारे सवाल हैं जो ऑनलाइन भी हमारे पास आए हैं। दैनिक जागरण से एक सवाल आया था इंटरव्यू टेक्नोलॉजी पे, कि इंटरनेशनल टेक्नोलॉजी का स्वास्थ्य रोगों पर क्या रोल है। लेकिन अब समय बहुत कम है, तो 2 मिनट में प्रधान छात्र से बात करूंगा कि आप इंटरनेटोलॉजी 2 मिनट आप इन लोगों को बताएं कि इंटरनेटोलॉजी का इंपॉर्टेंस क्या है, क्योंकि दैनिक जागरण से वो पहुंच नहीं पाए। मेरे पास जस्ट सवाल आया है बस।
लगा जल्दी करो। और लोग भी आ जाओ, जिसको करना कर लेता। इंटरवेंशनल इंटरवेंशनल पल्मोनोलॉजी, जैसा इंटरवेंशनल कार्डियोलॉजी होता है, वैसा इंटरवेंशनल रेडियोलॉजी होता है, वैसा इंटरवेंशनल पल्मोनोलॉजी करके एक फील्ड पिछले 10 से 20 साल में बहुत अच्छी तरीके से डेवलप हुआ है। इसमें मेन जो प्रोसीजर्स किए जाते हैं, एंडोस्कोपी जो की जाती है, वो है लंग्स की एंडोस्कोपी। उसमें 2 प्रकार के एंडोस्कोपी होते हैं, एक ब्रोंकोस्कोपी होती है और दूसरा एक प्लूरोस्कोपी करके एंडोस्कोपी की जाती है। अभी जो ब्रोंकोस्कोपी है, वो जो एक रेगुलर ब्रोंकोस्कोपी जो है, वो उसे हर छोटे छोटे शहर में, छोटे तालुका प्लेस में भी की जाती है और उसका डायग्नोस्टिक वैल्यू बहुत है। अब बहुत सारे जो डिजीजेस है जो खाली एक अनुमान के ऊपर ट्रीट किए जाते थे, जैसे कि टीबी है, उसका अगर हम ब्रोंकोस्कोपी करें तो उसका सही डायग्नोसिस हो सकता है। ब्रोंकोस्कोपी करने से वेदर वो टीबी जो है वो सेंसिटिव टीबी है या ड्रग रेजिस्टेंट
बस
टीबी है,
2 मिनट
इसमें
2 मिनट
बहुत
2 मिनट
हेल्प
2
होती है। अभी ब्रोंकोस्कोपी के आगे भी बहुत रेगुलर ब्रोंकोस्कोपी के
सर
आगे भी बहुत डेवलपमेंट्स हुई है।
हम लोग के
ब्रोंकोस्कोपी
पास
में ईबस
शार्ट
होता है,
टाइम
जो
है
कहते
थोड़ा
हैं
सा।
कि एंडोब्रोंकियल अल्ट्रासाउंड, जो
हाँ
ईबस
बस बस,
कहते हैं।
हमारे
ईबस
पास थोड़ा
टीबीएनए,
शार्ट टाइम है, अब थोड़ी
यस
सी
यस
डिस्कस कंक्लूजन कर देते हैं, कंक्लूजन।
कंक्लूजन कर देते हैं, राइट। तो ईबस टीबीएनए करके है, जो छाती में जो गांठ है उसकी बायोप्सी की जाती है। उसमें छाती की गांठ की अक्सर मोस्ट टीबी जो एक मोस्ट कॉमन डिजीज है, वो हिसाब से अनुमान से ट्रीटमेंट होती थी। अभी ईबस के वजह से वो जो छाती में गांठ है वो टीबी की गांठ है, कैंसर की गांठ है, सार्कोड की गांठ है, इसके बारे में भी पता है।
थैंक यू सर, थैंक यू। अभी चूंकि
प्रोसीजर जो है उसके लिए आपके आईएमएस में क्या फैसिलिटीज है, क्या व्यवस्था है?
हाँ, हमारे आईएमएस में इसका अच्छे से स्थापित विभाग है, जिसे कि रेस्पिरेटरी मेडिसिन विभाग कहते हैं, और वहाँ पर हमारे चिकित्सकों की अच्छी टीम है और
माइक
इंस्ट्रूमेंट है, इक्विपमेंट है, मशीनें हैं।
बस नहीं सर, कुछ
वहाँ पर सीटी स्कैन हमारा ये जितनी भी चीजें होती है सब कुछ इसका लाभ उठाया जा सकता है।
आम बीमारी जो है लोगों के लिए खराटे, इस तरह की बीमारी का शिकार व्यक्ति आगे है, उससे क्या व्यवस्था है इलाज की?
हाँ, उसकी व्यवस्था है। वहाँ पर लैब उन्होंने बना रखी है, जिसमें कि एक दिन के लिए मरीज को भर्ती करके उसके जो निर्धारित टेस्ट होते हैं करते हैं, और इसके बाद क्या किया जाता है वो अपने समय सर में होता है, उपचार किया जाता है सर। ऐसे उसका
हाँ हाँ हाँ, ये आप सर कट हाँ एक मिनट सर के साथ पसीजन कर लेना।
आम आदमी को क्या संदेश देना चाहेंगे? आम आदमी को एकदम ले मैं
देखिए, जैसे यहाँ पे एक कंसेप्ट पूरा आप ग्रीन का भी देख रहे हैं, तो आम आदमी को भी इस ग्रीन रेवोल्यूशन में सहयोग करना पड़ेगा। और अभी भी जैसे बार बार आपने कई बार अलग अलग सोशल मीडिया साइट पे भी देखा है कि हमें कम से कम 60,000 पेड़ भी लगाने पड़ेंगे, और हर एक इंडिविजुअल की जिम्मेदारी है उसको मेंटेन करके उसको आगे बढ़ाने की। और साथ साथ यही नहीं है, हर एक व्यक्ति को समझना पड़ेगा कि और अन्य कारणों से हम पोल्यूशन क्रिएट कर रहे हैं, तभी जाके हम इसको रोल आउट कर पाएंगे और सबका सहयोग होगा।
और हम आगे
हमारे साथ एक्सपर्ट डॉक्टर विवेक नाकिया है। मीडिया प्लीज अपने सवाल पूछें। ठीक है, यस।
सांस रोक नहीं पाता, प्रदूषण में और बहुत साइड इफेक्ट्स होते हैं, जैसे कि ब्रेन में स्ट्रोक हो सकता है। प्रदूषण क्या होता है? प्रदूषण में आते डस्ट आती है, टॉक्सिक गैसेस आती हैं। तो ये जब हम इनहेल करते हैं, हमारे लंग्स के अंदर जाती है, तो वो एक इन्फ्लेमेटरी कैस्केड ट्रिगर ऑफ करती है, जिसकी वजह से पूरे शरीर के ऊपर इम्पैक्ट
की तैयारी कर
उसकी वजह से हार्ट के ऊपर असर आ सकता है, अटैक हो सकता है, ब्रेन स्ट्रोक्स हो सकते हैं, लंग्स में कैंसर बन सकता है, अस्थमा बन सकता है, इंटरस्टिशियल लंग डिजीज बन सकती है, इन्फेक्शन ज्यादा हो सकती है। जो प्रेग्नेंट लेडीज हैं, उनमें बच्चे जो अभी बच्चा पैदा भी नहीं हुआ है, उसकी भी जिंदगी के ऊपर इम्पैक्ट पड़ सकता है, हो सकते हैं। तो बहुत इम्पैक्ट होता है एयर पोल्यूशन।
थैंक यू सर, थैंक यू। हमारे साथ जो है सीएमओ साहब है, उनको अभी चीफ मिनिस्टर के साथ एक मीटिंग में जाना है, तो मैं चाहूंगा कि हमारे चीफ गेस्ट हैं उनको हम वेलकम थोड़ा करना चाहेंगे 2 मिनट के लिए। हाँ प्लीज। हाँ
मैं रिक्वेस्ट करूंगा ऑर्गेनाइजर डॉक्टर एस के पाठक सर से टू प्रेजेंट अंगवस्त्रम। सीएमओ सर है उनके पास है।
आपकी बात सब तो हमारे साथ तो रहेंगे।
डॉक्टर एस के संखवार सर।
ऊपर हमारे साथ
डॉक्टर राजेंद्र प्रसाद सर। सुनील संदीप चौधरी सर, सीएमओ सर। थैंक यू वेरी मच सर फॉर योर वैल्यूबल टाइम। अभी कार्यक्रम को हाँ दीप प्रज्वलन करके हम अपने कार्यक्रम की शुरुआत करेंगे और हम सभी अपने चीफ गेस्ट को
यस। अभी हमारे साथ सारे फैकल्टीज हैं, मैं उनका वेलकम थोड़ा लेट करूं क्योंकि हमें सेशन में लेट हो जाएगा। प्लीज हम लोग इनाग्रेशन और दीप प्रज्वलन के लिए प्लीज
हम अपने सभी चीफ गेस्ट से अनुरोध करेंगे कि दीप प्रज्वलन के लिए कृपया आगे बढ़े। कोई पंडित जी है, इसको मंत्र यंत्र आता है? जाओ जाओ जाओ। जोरदार तालियों से सभी अभिनंदन करेंगे।
एक मिनट एक साथ आ जाइए। थोड़ा नीचे करो, टाइम आगे। थैंक यू। आज जो है डॉक्टर स्टेज इवनिंग में करें तो थोड़ा सा माल्यार्पण हम
चूंकि कल डॉक्टर्स डे है, इसलिए हम लोग डॉक्टर बीसी रॉय सर का माल्यार्पण करेंगे। और इस सेरेमनी को हम लोग केक काट के भी सेलिब्रेट करेंगे। सुनील जी, केक केक थोड़ा आगे करवा दीजिएगा। संदेश जी, ये दीप प्रज्वलन वाला बाहर करवा दीजिए। धुआं कर रहा है, देखिए गिरे ना। हाँ, इसको बाहर कर दीजिए। थोड़ा मीडिया वाले से अनुरोध है, थोड़ा डॉक्टर्स लोग को प्लीज जगह दे दीजिए पीछे और हो। फर्स्ट जुलाई डॉक्टर्स डे को सेलिब्रेट करने के लिए हम लोग केक कटिंग करेंगे।
मैं आया एक मिनट जी।
सर आप भी लीजिए केक। स्वप्निल, स्वप्निल, सर इनको बुलाए। हैप्पी डॉक्टर्स डे।
अच्छा सर, सर
वहीं पे बुला लो।
हाँ सर,
वहीं बुला लो।
सर एक मिनट।
अच्छा अच्छा, वहीं पे बुला। हाँ आराम।
अब हम लोग हाई टी के लिए ब्रेक करेंगे और 15 मिनट के बाद। अच्छा ठीक है, लाइव।
आइए।
हाय सर, हाय सर, आइए
जाओ भाई बैठ जाओ।
आ जाइए सर। मीडिया मीडिया
आ गया। अरे बैठो।
बस बस अब
थैंक यू सर।
ट्रेंड भैया किसी ने मान सर एक आपके साथ फोटो है 14 से आ रहा है 10 साल से अच्छा ये आप सभी हमसे इतने अच्छा करो बहुत जरूरी है साल में एक बार जरूर भैया प्रेस वाले थोड़ी देर बैठ जाएं हो गया जाइए
हम कम समय में जिस मॉडल के संबंध में हमारे साथ कई सारे एक्सपर्ट जुड़ चुके हैं, अब तक 35 से ज्यादा एक्सपर्ट जुड़ चुके हैं इन जगहों से, और आज हमारे साथ जुड़े भी हैं और उन सबके साथ रूबरू हो गए। इसमें कई सारी बीमारियों के बारे में, सांस बीमारी के बारे में चर्चा करेंगे जो बहुत ही महत्वपूर्ण होगी।
बैठ जाइए थोड़ी देर आप लोग।
Very good evening, सभी लोगों को. Today on this occasion of the 11th Respiratory Conclave Conference, so, present over here on the dais, teachers of teachers, Professor Rajendra Prasad sir, who has been my teacher at Kidney Medical University. He is not only teacher, but he is a very nice human being, always helping. I worked with him as a capacity of assistant warden of the hostel. Sir was very precise and very keen to know each and everything and how to help the student and maintain the sanctity of any hostel. So, sir is a yes, sir. Sir was warden for a long time, about 25 years, and very disciplined hostel. So, thank you, sir, being here and also inviting me in this conference. And here Dr. K.K. Tripathi sir, Padam Shri sir, he is a legend in field of the medicine and our teachers in BHU. Our very dynamic, hardworking Chief Medical Officer of Varanasi City, Dr. Sandeep Chaudhary sir. Guest Dr. Prasant ji, Dr. Nagia sir, Dr. Prabhu Desai ji, Dr. Vivek ji, and overall the organizer of this conclave, Dr. S.K. Pathak ji and his team, persons from the media and delegates from this and the delegates who are attending this workshop through the online mode. I welcome you all on behalf of this Varanasi city and for myself. And really it is a great thing to organize such a conference which is very helpful. And many questions are asked by the media person, very pertinent question, and those are very helpful for the general life as well. So I hope this conference will enrich the knowledge of each and everyone and that you can apply for the mankind. और कहा गया है कि I also welcome our medical superintendent and professor of the medicine Dr. K.K. Gupta sir. Welcome sir. तो कहा ही गया है कि अपने आप को स्वस्थ रखना बहुत जरूरी है और हमारे ऋषि मुनियों ने भी कहा है कि पहला सुख निरोगी काया, दूसरा सुख घर में माया, तीसरा सुख कुलवंती नारी, चौथा सुख पुत्र व आज्ञाकारी, पांचवा सुख संतोषी जीवन, और अगर ऐसा है तो धन्य जीवन. फिर घूम के आ जाते हैं उसी की पहला सुख निरोगी काया. तो अपने आप को स्वस्थ रखना दैट इज मोस्ट इम्पोर्टेंट फॉर एवरीवन. और आपका स्वास्थ्य का ख्याल रखने आपको ही करना पड़ेगा. अगर आप नहीं करेंगे तो आपका ही कार्य कोई दूसरा नहीं कर पाएगा. तो डॉक्टर राजेंद्र प्रसाद सर ने जैसे पहले ही कहा था कि स्वस्थ आहार, स्वस्थ जीवन शैली और स्वस्थ विचार ये सभी आवश्यक हैं टू बी हेल्दी. So I extend my best wishes for the successful celebration of this conference. Thank you very much. Jai Hind.
थैंक यू सर. अभी सभी रिस्पेक्टेड फैकल्टीज को मैं बोलूंगा कि हाई टी के लिए रेडी हो, उसके बाद हम लोग सेशन करें. हाई टी जस्ट इन द कॉफी टी प्लीज कम. ऑल मीडिया पर्सन्स प्लीज ज्वाइन द हाई टी. वहां पर
हाँ और भाई साहब क्या हाल चाल है? तो वहाँ बंदा आया था। हाँ हाँ ऐसा ही है हमको भी यही लगा और ये मुस्कुराइए
Yeah. I'm not in the way. I mean, वाराणसी सर क्यों कर रहे थे ना? नहीं वो सेंड नहीं करना पड़ता तो देख करके फिर आके वाराणसी सर डायरेक्ट सेंड ऑप्शन आपने दे रखा है कमांड दे रखा है तो हर उस पे जो है आप पूछेगा कि बता आप टू सी वन बच्चों के बारे में तो बता दिए दवा बनी है तो आपको दर्द दवा का खत्म किया है अगर बता ही देगा तुम्हें दर्द उसको दर्द हो रहा तो क्या करोगे आई देगा हमको दर्द करा तो क्या करोगे आ रहा है तो पूरी से खाई आ रहा है तो पांच से कोई काटना अगर एक काटता है हमसे बोल के लिए रहता है ये बातों को समझ गए ना इससे ज्यादा संभव नहीं दवाई वाला है हाँ
इस चेयर को ऐसे लगाना दो चेयर इधर लगा दो, दो चेयर ऐसे लगा दो, ठीक है, बाकी सब हटा दो। सब हटा दो। दो इधर, दो इधर। ठीक है, बीच में रोक दो, बीच में तो ऐसे से दे दो, मतलब जो बैठेगा वो थोड़ा टेबल वाला पहले ये दो था और फिर चार छोड़ बीच में हटा दो, दो उधर तो दो इधर लगे। चेयर पर्सन के हाँ, स्पीकर अपना वहां बोले, चेयर पर्सन मिले, दो इधर दो इधर, बीच का पूरा खाली जाएगा।
चार रखना है आप, चार रखना है, चार एक रस निकल जाए, वो रस निकाल दे। कौन सा रखना है?
स्वप्निल पाठक है। हाँ तो स्वप्निल के बारे में बोल दूंगा। हाँ बट कंट्रोवर्ट का इनका है। हाँ तो नेक्स्ट हो जाएगा ना। ठीक है तो साथ में सबकी बेटी है और कोई है फिर अभी बाकी है नेक्स्ट फिर उसमें अलग है फिर उसमें अलग अपना मैं एक है। जी जी सर ये आपके लिए सर ये है ना सर मेरा तो प्रशांत सर करते हैं सर प्रशांत करते हैं तो आपके सेशन में तीन मतलब सर तीन होने अभी पहले सेशन में शुरू सर फर्स्ट में आप आएंगे सेकंड और थर्ड में हो सकता है सर चेंज करवा दीजिए हाँ एक ये और सेशन वन लेक्चर टू और सेशन में 3 लाख इंट्रोडक्शन टू तो उधर लगा कि बीच में टेबल अच्छा ऐसा और पीछे लगाओ और पीछे बस बीच में करो और बीच में करो और पीछे करो इसको और पीछे इसको और पीछे करो नहीं इसको बॉल नहीं उधर से आगे बढ़ाना उधर एक्चुअली बीच का खाली रहने को बीच में विजुअल जाएगा एकदम पीछे कर दो गिरे ना बस और ये एक इधर कर दो एक उधर कर दो एक उधर ऐसे लगा दो थोड़ा सा तिरका कर दो बस एक उधर सेम चीज उधर रहेगा चेयर पर सुनो और स्पीकर माइक दोनों माइक जो है दोनों दिखाते माइक दिखाना तो एक सेकंड Everything is fine. इसके लिए तो अच्छा तो आपको देता हूँ एक बार चेक करिए So, moving towards our next program, जैसा कि आप लोगों को जानकारी होगा कि जनरल प्रैक्टिशनर्स डॉक्टर्स के लिए हम लोग ब्रेतीजी की तरफ से एक पत्रिका हर 3 महीने पे लॉन्च करते हैं, जिसका बेसिक ऑब्जेक्टिव ये होता है कि मेडिकल में क्या नई चीज़ें आई हैं, क्या नई-नई चीज़ें आई हैं, नई-नई पद्धति द्वारा अस्थमा मरीजों का इलाज या पेशेंट्स का कुछ फीडबैक या पेशेंट्स का उसका स्टोरी। तो उसके लिए इस बार हम लोग जो है इसको हम लोग लॉन्च करने वाले हैं। तो उसके लिए हम अनुग्रह करेंगे डॉक्टर प्रशांत छाछड़ सर से। प्लीज़ कम ऑन द डायस। Dr. Vivek Nagia sir, Dr. Prahlad Prabhu Desai sir, Dr. PC Kathoria sir, Dr. Rajendra Prasad sir, Dr. KK Tripathi sir, Dr. KK Gupta sir, and Dr. SK Pathak sir. डॉक्टर प्रभु देसाई हर बार अलग अलग टॉपिक्स पे ये बीई टाइम्स के नाम से हम लोग लॉन्च करते हैं। इसको डॉक्टर ही नहीं सिर्फ पेशेंट भी पढ़ते हैं और अपने फीडबैक्स इसमें देते हैं। मैं रिक्वेस्ट करूंगा अपने सभी चीफ गेस्ट से कि उसको ओपन करें। तो तुम थोड़ा सा पीछे हमारे जगह नहीं, प्लीज लुक हियर सर, सीधा सीधा सीधा। Thank you very much, sir. Sakshi, ready? Once again, on the behalf of whole Respiratory Conclave team, I Abhishek welcomes you all. Now moving towards further session, would like to call Dr. Sakshi Pathak.
Namaste and good evening, everyone. Myself, Dr. Sakshi Pathak, Program Coordinator for Respiratory Conclave Conference 2024. It is my privilege to welcome you all to RCC 2024 in the sacred city of Varanasi. As we gather on the banks of River Ganga, we are reminded of the ancient wisdom and spiritual heritage that has shaped our understanding of health and wellness. Today, with heated discussions on various topics in the field of pulmonology, we'll be divulging into new cutting-edge topics, explore new frontiers in the field of pulmonology, from intricacies of lung function to latest therapeutic breakthroughs. Our conference program promises to inspire, educate, and challenge your perspective. I'm also very proud to share with you that this year we'll be completing 10 years, and this will be our 11th Respiratory Conclave Conference, during which a total of 32 faculties have been a part of our program, and we are hoping for many more in future. Now let's begin with the schedule of today's conference. Today's conference will be divided into 3 sessions, each session consisting of various lectures on various topics. So for the first session, the first topic is Introduction to Interventional Pulmonology by Dr. Swapnil Pathak sir, MBBS DNB Pulmonary Medicine, Max Super Specialty Hospital, New Delhi. The second topic will be on the role of interventional pulmonology in daily practices by Dr. Prashant sir, interventional pulmonologist, head of respiratory medicine, Fortis Hospital, Navi Mumbai. The third lecture will be on approach and management for undiagnosed tuberculosis in clinical practices by Dr. Vivek Nagia sir, Max Super Specialty Hospital, New Delhi. The second session will begin with the first topic of new treatment strategies in asthma and COPD by Dr. Prahlad Prabhu Desai sir, Department of Chest Medicine, Leelavati Hospital in Mumbai. The second topic will be on role of pulmonary function test in clinical practices by Dr. SK Pathak sir, Senior Pulmonologist, Breath Easy Hospital, Varanasi. The third topic will be on role of artificial intelligence in respiratory medicine by Dr. Rajadhar sir, Senior Pulmonologist, Kolkata. The fourth topic will be on clinical pulse in interstitial lung diseases by Dr. Deepak Talwar sir, Director Pulmonary and Chest Medicine, Metro Hospital, New Delhi. Now, the third session will begin with the topic of allergen immunotherapy in practices of allergic asthma by Dr. PC Kathoria sir, Senior Consultant, Department of Allergy and Asthma, DLK Super Specialty Hospital, New Delhi. And the last session will be on the topic Clinical Pearls in Respiratory Allergy by Dr. Rajendra Prasad Sir, Director, Medical Education and Professor, Respiratory Medicine, ERAS, Lucknow Medical College and Hospital, ERAS University. Followed by a conference quiz conducted by Dr. Swapnil Pathak and a token of thanks by Dr. S.K. Pathak, sir. Thank you very much. Mr. Abhishek, I would like to transfer the session to Mr. Abhishek for further coordination. Thank you.
Thank you, Dr. Sakshi. Moving towards our first session, would like to call Chairperson, Dr. Sanjay Kumar Sir, IMS BHU, and Dr. Mohit Bhatia Sir, IMS BHU, and Dr. KK Tripathi Sir, IMS BHU. Sir. सर एक लोग इधर आ जाओ इधर आ जाते हैं उधर उधर
So we'll begin the first session, and the first speaker is Dr. Swapnil Pathak. He is a brief introduction. He's MBBS from ERAS Hospital, DNB, Pulmonary Medicine. Currently, he is working at the Max Super Specialty Hospital, New Delhi. He has done his fellowship in respiratory medicine, and he's associate director at Breathizi Hospital. He's going to talk on the introduction to the intervention pulmonology. So we invite Dr. Swapnil Pathak to start the session with his talk.
Thanks a lot, sir, for this brief introduction. So, hello and good evening to all the guest speakers, chairpersons, panelists, and our delegates. It's really my pleasure to speak in front of you all. It's my immense pleasure this time to welcome my mentor and my guru, Dr. Vivek Nangia, into this RCC this year. So, the topic that has been allotted to me is a brief introduction to intervention pulmonology. So, details regarding this topic will be discussed and dwelled with my other seniors in the next subsequent sections. So let's just begin with this topic. So interventional pulmonology is quickly evolving subspecialty of pulmonary medicine, offering minimally invasive procedures for the mediastinum, lungs, airway, and pleura. The range of procedures includes diagnostic and therapeutic options for both benign and malignant diseases of the lungs. Imaging plays a key role in identifying patients who will benefit from intervention pulmonology procedures, detailing the relevant anatomy and measurements of our procedures planning and monitoring patients for successful outcomes and complications related to these procedures. So the contents of this lecture will be, so I've divided this kind of a topic in two parts. The one are basic procedures that are dealt in pulmonology, and another is advanced procedures in pulmonology. So I'll go one by one. With respect to basic procedures, there are USG guided needle thoracocentesis, pleural tap, chest tube insertion, flexible fiber optic bronchoscopy, medical thoracoscopy slash pyroscopy, can be rigid, can be flexi-rigid, ultrasound or CT guided percutaneous transthoracic needle biopsy. And in advanced procedures, there are certain procedures like IPC, indwelling pleural catheterization, cryo techniques in pulmonology, therapeutic bronchoscopic interventions, curvilin probe, EBUS guided transbronchial needle aspiration and transbronchial mediastinal cryobiopsy, and radial EBUS, autofluorescence bronchoscopy and OCT of airways, navigational bronchoscopy, augmented fluoroscopy, virtual bronchoscopy, and robotic bronchoscopy. These are certain newer things that have been evolving in branch of pulmonology. So ultrasound guided needle thoracocentesis or pleural tap. So I'll just briefly talk about the indications of all these procedures. So there are certain diagnostic indications to determine nature, that is exudative versus transudative, and potential cause of pleural effusion. Therapeutic, that is large volume thoracocentesis to be done in cases where moderate to large pleural effusion is there, causing dyspnea, hemodynamic instability. Chest tube insertion, what are the indications? Pneumothorax can be primary spontaneous pneumothorax, persistent or recurrent after simple aspiration. Secondary spontaneous pneumothorax, tension pneumothorax after an initial needle aspiration in any ventilated patient, if there is a pneumothorax. Malignant pleural effusion, empyema, and complicated and parapneumonic pleural effusion. Traumatic pneumothorax, post-operative cases, example after esophageal or cardiac or pulmonary surgeries and pleural surgeries. Mediastinal or pleural surgeries. Treatment with sclerosing agents, or that we call pleurodesis, can be with the help of chemical agents, can be with the help of talc. Post-pneumonectomy BPF cases. So third one is diagnostic flexible fiber optic bronchoscopy. So certain indications, as in for evaluation of sign and symptoms like hemoptysis, stridor, unilateral wheezing, hoarseness of voice, unexplained chronic cough. For infections of evaluation and diagnosis of infections like pneumonia, immunocompromised host, non-resolving pneumonia, cavitatory lesions. For DPLDs like ILD, diffuse alveolar damage and hemorrhage, drug-induced lung disease. For evaluation of certain malignancies like lung nodules or mass. For other airway disorders like extracting mucus plugs and all. Foreign body aspiration, benign airway strictures. So of course most of them are diagnostic, and few of them are also therapeutic interventions. In case of ICU, bronchoscopy guided intubation as in difficult airway, endotracheal tube position, we can take the guidance of fiber optic bronchoscopy in it, and certain other miscellaneous cases. So what is medical thoracoscopy or pleuroscopy? There are certain indications of this kind of a scope which goes into your intercostal space, and for evaluation diagnosis of undiagnosed exudative pleural effusions, staging of lung cancer with pleural effusion, and staging of malignant mesothelioma. Thoracoscopic talc podrage for recurrent malignant pleural effusion. So what's this? This is ultrasound guided or CT guided percutaneous transthoracic needle biopsy. Although this kind of procedure is dealt with interventional radiologists nowadays, but we can also go with this procedure. What we do exactly is it's indicated in evaluation of solitary lung nodules and masses, mediastinal and hilar lesions, metastatic diseases to lung from a known extrathoracic malignancy, chest wall invasion by lung carcinoma, pulmonary consolidation or infiltrate that are likely to be of infectious origin. So what is important with respect to this ultrasound or CT guided percutaneous transthoracic needle biopsy is that for peripheral pulmonary lesions, we usually go for this. So what are the advanced procedures in pulmonology? So one is IPC, indwelling pleural catheterizations. It's indicated in the condition where patient with malignant pleural effusion with or without non-expandable lung. So in this situation, we can go for IPC. Rapid accumulation, that is within 1 month after large volume thoracocentesis. In these cases, we can offer IPC. Patient who has failed pleurodesis and does not prefer a repeat pleurodesis. So that is very important in patients when there is a failed chemical pleurodesis or a talc pleurodesis, we can offer these patients a IPC. So there are certain cryo techniques in pulmonology. So basically, the cryo, this is a cryo technique which has principle which I'll not deal with right now. So there are certain methods: cryoablation or destruction, cryoadhesion or extraction, cryobiopsy, as in TBLC using 1.9 mm probe, or TMC, that is using 1.1 mm probe, and cryo recanalization. So I'll specifically focus on cryobiopsy, that is very commonly used nowadays. So the uses are endobronchial cryobiopsy during bronchoscopic resection or recanalization, TBLC for diffuse ILDs, and TBMC for mediastinal lymph nodes. With respect to TBLC, although original observational studies suggested that the rate of complication was low, that is less than 5%, subsequently studies report that higher pneumothorax and bleeding rates than standard transbronchial biopsy. So that is what the difference is in transbronchial cryobiopsy. The complications are comparatively lesser than the conventional transbronchial lung biopsy with the help of a forceps. So if we can see this console, it has got a cryogen cylinder which contains pressurized carbon dioxide, N2O, or liquid nitrogen. A cryogen cylinder then delivers this gas into this this cryo console, and then after this cryo console, it ultimately transfers to the cryo probe where we are kind of going to get a biopsy from. And there's a foot pedal which we can use to deliver the gas. It kind of a pressurized gas delivered at a particular focus, kind of freezes there, and then so freeze and thaw kind of a principle. We freeze a tissue and then we thaw. Sometimes we freeze and extract, sometimes we freeze and then we thaw and then take the tissue. So with respect to different kind of procedures like cryoablation and cryoadhesion or cryobiopsy, different techniques can be used. So therapeutic bronchoscopic interventions are also available nowadays. So I'll quickly talk about these. So rigid bronchoscopy and its diverse therapeutic role. Flexible bronchoscope has to a larger extent replaced the rigid bronchoscope for most diagnostic and some therapeutic indications. Rigid bronchoscopy still has got some vital role with respect to intervention pulmonology. So the indications of therapeutic, this rigid bronchoscopy allows a number of therapies such as endobronchial laser, photocoagulation, placement of endobronchial stents, silicone or SEMS, endobronchial balloon dilatation, electrocautery, organ photocoagulation, that is APC, cryotherapy, brachytherapy, photodynamic therapy to be performed safely and effectively. So these are certain therapeutic procedures that can be performed via a rigid bronchoscope. So if you can see that this is balloon tracheobronchoplasty. Using an electrocautery incision were made into the benign stenotic lesion. So there was a stenotic lesion which was benign. So one has basically entered into the airway using this balloon, and they kind of dilated this narrowed structure. This is endobronchial silicone stent placement, in which we can see there's a large tumor nearly completely obstructs the tracheal lumen. So there was a manual debulking which was performed by a rigid bronchoscope, and then which ultimately improved the luminal diameter of the airway, and then we placed the endotracheal silicone stent which into the trachea. Bronchoscopic lung volume reduction in advanced COPD cases. So basically indicated for heterogeneous emphysema, which is bilateral upper lobe predominant on CT scan. So there are certain techniques by which we do bronchoscopic lung volume reduction. So this is not a surgical lung volume reduction. This is bronchoscopic lung volume reduction. So there are three principles: targeted lobe atelectasis, either using a one-way endobronchial coils or self-activating endobronchial valves. And second principle is targeted destruction and remodeling of the emphysematous tissue using bronchoscopic thermal vapor ablation and lung sealant. So basically it's a airy seal kind of a thing which is sprayed into the airway, and then it kind of destructs the emphysematous tissue. And third, the principle is bypass tract stenting or transpleural ventilation using endobronchial stents. So to quickly show the images, so these are Zephyr endobronchial valves and this spiration valve system. Bronchoscopic thermal vapor ablation, endobronchial coils that we can see on the chest X-ray. Multiple coils are placed in the I think right upper lobe. BLVR stents. So as you can see, so this bypass stent is very small. It's like a pencil tip, kind of bypasses the airway tract. This is lung sealant, airy seal system, goes and destroys the airway. Bronchial rheoplasty is a technique. So this is not part of BLVR, but bronchial rheoplasty and targeted lung denervation are also used techniques for advanced COPD cases. So my seniors will deal with all this thing in the subsequent lecture. This is liquid nitrogen metered cryo spray, Rejuven Air. Bronchial thermoplasty for patients with severe asthma. It is also kind of based on basically high temperature goes there and ablates the mucosa of the airway for the severe asthma patients. So I'll not deal with the concepts of all these procedures, where are indicated, what are the indications, contraindications, and the concept and principles behind it. But I'm just giving an overview of all what all happens in IP basically. So this is EBUS, TBNA, and TMC. That is what. So indications are. So this is a special kind of a bronchoscope known as EBUS scope. It can be a curvular probe EBUS, can be a radial probe EBUS. We can go there. We can take pass a needle and take a aspirate from a mediastinal lymph node, which is suspected to have some either malignant or non-malignant disease. and we can also take a biopsy from those nodes also. So so what are the indications? Evaluation, that is sampling of mediastinal masses and mediastinal and hilar nodes that are more than equal to 1 centimeter using EBUS TBNA, EBUS TMC, or EBUS IFB. Diagnosis, staging, and restaging of lung cancers, especially for non-small cell lung cancer. Evaluation of pulmonary nodule, endobronchial or peribronchial lesions to guide therapeutic interventions, example airway stenting. So this is our radial probe EBUS. So basically goes inside and gives a 360-degree view of the airway. So this is EBUS transbronchial mediastinal cryobiopsy. I've already discussed the cryobiopsy principle, in which we can use a probe that is 1.1 mm. It can go inside, take a biopsy from the mediastinal lymph node. So as we can see, the hyperechoic structure which is inside the node, which is basically a cryoprobe. So we can even evaluate a tracheobronchial mucosa using certain dyes. This is called as autofluorescence bronchoscopy. There's also airway OCT that is available to look at the various layers of the airway, the mucosa, submucosa, and all. So this is called as airway OCT. As we've already heard of ophthalmology. In ophthalmology, the OCT are used basically to evaluate the layers of retina. Similarly, we can use the airway OCT for this. So these are all bronchoscopic techniques. So in the last, there is bronchoscopic evaluation of SPN and peripheral pulmonary nodule. There has been a continuous emphasis on the improving the ability to access and sample peripheral pulmonary nodule through technological advances in electromagnetic navigational bronchoscopy, augmented fluoroscopy, and virtual bronchoscopy. Furthermore, these guided bronchoscopy techniques can be combined with each other using ultra miniature radial probe EBUS, guide sheaths, ultra thin bronchoscopes, and most recently robotic bronchoscopy systems. So basically, peripheral pulmonary nodule, it's a broad kind of a topic which basically we can go for a transbronchial transthoracic biopsy via ultrasound or CT guided. We can also go via the bronchoscopic technique, but it's kind of very difficult to localize that nodule and to take a appropriate sample from that nodule, because without these kind of a systems which are available now, just with the radial probe we cannot exactly know that whether the so first of all, we go inside, take a localize the nodule with the help of radial probe EBUS, and then we kind of come out with the radial probe, and then we again go with the help of this biopsy forceps, and then blindly take a biopsy. We don't know basically whether the biopsy which was taken was from the nodule or not, from exactly the nodule. So these systems are basically useful. So use of a virtual bronchoscopy based system for navigation. So this A is a chest CT image of a speculated left upper lobe pulmonary nodule. B image shows a 3D reconstruction of the tracheobronchial tree with the nodule identified. And C is virtual bronchoscopic image, that is endobronchial virtual bronchoscopy image of that particular nodule from in that subsegmental level. And then with the help of this bronchoscopy, this is a robotic bronchoscope which can be used, but not really available in India. But this navigational bronchoscopic systems are available that in this we can integrate the CT scan of the picture and kind of localize the nodule and then take a sample from there. So this is the virtual bronchoscopic navigation system. So thanks a lot.
Thanks, Swapnil. I have a small query before we open to the audience. And I was looking the list very precisely. We internist physicians face quite often problem of post-tubercular bronchiectasis. In spite of good anti-tubercular treatment in the past, these patients, they keep on coughing blood infrequently, frequently. And the surgeons used to perform. So what is the role of now minimal access surgery, which Sanjay might be doing, or with these instruments? How frequent we are able to pick up? Because they have a destroyed bad lung, their bronchiectasis, either you go for the pneumectomy, which is a difficult procedure, and most of the time they are not opted for. I have Dr. Jauhari with me, and I keep on troubling him also with such patients. Where is the role of this new procedure, EBS, or maybe minimal accessible surgery?
So you were asking about the bronchiectasis, especially.
Bronchiectasis recurrent. These patients keep on coughing blood. So either you do good angiography and try to pick up the blood vessel and then try to thromboize.
For diagnostic
Well,
purpose or therapeutically?
yeah, I want your answer with these any one of these instruments,
I think
robotic.
bronchial thermoplasty can embolization. Okay.
I said that, but
Okay.
often even it doesn't work. Depend on the extent of bronchiectasis that is there. If it is localized to one lobe, the other lung is healthy, patient is fit for surgery, and it's recurrent infections, recurrent massive hemoptysis, then yes, the patient should be operated, and that will give them a lifetime cure for it. But if it is bilateral disease, lungs are poorly damaged, poor lung reserves, cardiac issues, other comorbidities, then the patient will be unfit for surgery. So in basically you have to see at the extent of bronchiectasis and the fitness for surgery. And of course, they can do a lobectomy, they can do a segmentectomy, they can pneumonectomy is not done now unless it's like really extensive and really causing a lot of problems. But yes, they can be operated. Your experience?
Yeah, I agree, sir. The recurrent hemoptysis is very commonly the presentation of these cases. These cases are referred to us. But when the patient are stable and we really look at all the radiological diagnostic evaluation of those patients, so based on that, decision is taken. As you said clearly, that if it is a small area that is involved and we know that there's a focal lesion, then surgery is the option. We do take the help of the intervention radiology people as well, because if sometime it looks like the recurrent hemoptysis and patient is not really fit to undergo surgery, then in that case, we ask the opinion of the intervention radiology if they can embolize those culprit vessel and so that it can be cured. I have one question for you. This is about the endoscopic lung volume reduction using those endobronchial valve. So, mix. We know it is because I've mostly I've heard about the theoretically only, but majority of the time the cases are referred to us for lung volume reduction surgery. And I just if you guys have experience on that, so I just want to know exactly how many. Is it like a stage procedure? You do it in multiple session and use the valve selectively for those bronchial or whichever that emphysematous area is there.
So, endobronchial treatment of emphysema is another word for that.
Yeah.
So far, to the best of my knowledge, it is not available in India yet. I do have experience using that in Europe. It is typically, it may be done in a staged manner also, depends on the target. But typically, we don't like to do two sides at the same time, because the risk of pneumothorax is very high and you don't want the individual to land up with a bilateral pneumothorax. So typically, if you're thinking of doing bilateral, then it would be in a staged manner. On one side, you can do two lobes at a time. That's not a problem.
That's right. Because I always find the merit of having this endoscopic procedure, because those culprit areas you take care, and it allows the remaining normal lung to expand, so that uh, reduction takes place in a very effective manner. Because when we go surgically, we take out a lot of the bits which may be even normal looking lung, because unless we are sure that is only the emphysematous area. So that's the problem.
Basically, what you need to see is whether this is a heterogeneous or a homogeneous emphysema, then whether there are collateral air channels available or not. If that is happening, then no procedure will really help except for surgical excision. If there is no collateral channel happening and it's a unilateral disease, again like a Buller's disease or a heterogeneous emphysema, predominantly the upper lobe disease, then they benefit with the use of all these endobronchial therapies, which may be in the form of valves or BTVA. BTVA is now available in our country, but again, very limited experience because the selection criteria of these patients is very, very strict, and not many patients really fulfill that criteria. So, but endobronchial therapies are known to have better outcomes as compared to surgical outcomes in these patients, because one, most of these patients are moribund, they are end stage lung diseases, they are unfit for general anesthesia, prolonged general anesthesia. So the comparison between the two groups has been seen to be better for the endobronchial therapy patients.
Thank you.
Okay, thank you, sir. So, to present one question. Okay, please.
Yeah, there are.
My question is, are you doing thermobronchoplasty in your center? And how effective is in severe asthma
So there
management
are few cases
cases?
with Dr. Angia sir tried severe asthma cases, bronchial thermoplasty.
So we've done it in about 2 patients so far, had very good results. But then for some reason, there has been a lot of controversy around the modality of treatment in these patients. And now the biologics are being used more than bronchial thermoplasty. So bronchial thermoplasty was classically reserved for patients who did not qualify for any of the biologics also. But then for some reason, we are still not very clear why it is happening. But thermoplasty does seem to have a lot of potential in management of these patients, but has gone out of favor for some reason. I guess Prashant would be able to highlight this better.
So for thermoplasty, I think it has a very good role, particularly now when the thermoplasty trials were done, that time we did not have biologics, so it was done for all patients who had severe asthma. Now there is some sort of a phenotyping, people who are qualifying for biologics, people who are not qualifying for biologics, or people who are failing biologics. So there is a role, selective role for thermoplasty. We've had good experience with thermoplasty. There has been the controversy is more from the industry side in terms of providing the catheters, etc., which are needed for thermoplasty. So, of course, dominant number of patients who have severe asthma can do well with biologics, and of course, therefore, as I said, you have to phenotype them and identify which are that small subgroup of patients. See, severe asthma is a small group subgroup. Within that, the individuals will qualify for thermoplasty is a small subgroup. It is a good modality in selected patients.
Thank you very much. So to present Angvastram and memento to our young and upcoming Dr. Swapnil, I would like to call another young and dashing pulmonologist of Varanasi, Dr. Robin Dubey sir. कहाँ बाहर चले गए थे? इधर आओ, इधर आओ. Dr. Robin Dubey sir is not. I would like to call Dr. Vikas Jaiswal sir, another young and handsome pulmonologist of Varanasi. Thank you very much, Dr. Swapnil.
Moving on to the next topic in this session, which is the topic of this session is role of interventional pulmonology in daily clinical practice. As in the last lecture, Swapnil has opened the gate for the interventional pulmonology. Now we will have this wonderful presentation from Dr. Prashant Chanjar sir, who needs no introduction. He is the one of the pioneer in a field of interventional pulmonology, and he is doing lots of interventional procedure. And sir is 25 minutes time noted, please. Now I am handing. Okay, and now I hand over the mic to the sir for his presentation.
So, thank you very much, Dr. Pathak Saab, for this very kind invitation. And I think the foundation for this lecture has already been very well set by our earlier speaker. And so, it's made my talk easier. What I am going to do in the next 25-30 minutes is just give you a practical overview of interventions in daily practice. This is the word, daily clinical practice. You must have seen many things such as navigation systems. There are volume reduction systems, thermoplasty. Yes, they are done in select centers, but the point is in daily practice, what all can be done and what is very important, and the numbers are quite high. The spectrum has already been discussed by the earlier speaker. So let me start with the case presentation. I'll run through this very fast. 54-year-old female. She presents with breathlessness. Saturation is 91% on room air. X-ray shows bilateral reticulonodular opacities. PFT shows severe restriction, and there is a significant desaturation on the 6-minute walk test. If you see the HRCT chest, it says ill-defined reticular nodular opacities in both lung fields, showing a centrilobular distribution. Fine reticular densities are also present. Now there is an interstitial lung disease pattern, and she's a very young lady. We need a very precise diagnosis for this particular patient. Okay, so it is a ILD under investigation. And we do the regular workup. Connective tissue disease markers are normal. IG was normal. IG specific for pigeons dropping is normal. And therefore, at that time, this was done many years ago. The discussion was, should we do a VATS? So VATS was in fashion. That is video assisted thoracoscopic surgery, open biopsy. They were in fashion. Or the other option was a transbronchial biopsy. VATS came into fashion because you could get, or became important in practice because you could get bigger tissue and you could make a better diagnosis. But and she was an ophthalmologist wife, so she said, okay, we first like to do we want to take the chance of doing a transbronchial lung biopsy. Even if the tissue is small, they wanted to take a chance and see if it is not diagnostic, then we would move to a VATS surgery. So this is how a transbronchial biopsy is done. A forceps is passed through the bronchoscope. You just saw that. Okay, this is a very important procedure, can be done at almost all institutions which have bronchoscopy, therefore can be done in a routine practice. And this on the C-arm, you can really see how the forceps opens and a biopsy is taken in this particular case. Okay, and this is the histopathology report. Okay, the histopathology says interstitial pneumonitis with the possibility of parasitic etiology suggested, because they were also cross section showed calcified parasitic larvae. What is the point? I'm not trying to show you a rare case. I'm trying to show you that transbronchial lung biopsy is a tool which can be used in regular practice, and whenever it is appropriate, we should optimally utilize these tools to obtain biopsies. And this is what the histopath was seen in this particular patient. So we could get a diagnosis, and then we went ahead. We found out that she has a history of trekking in the Himalayas. So that's a big different story. And then, she had craniocephalous granulomas also in the muscles. So that's a different story. But the point is that in this particular case, transbronchial lung biopsy was very helpful. Now, this is another case. Okay, 58-year-old male, a young individual who has got cough, has got breathlessness, brother has died of interstitial lung disease, spirometry is normal, diffusion is impaired. Okay, and he is now diagnosed to have a interstitial lung disease. So in interstitial lung disease, there are some diagnoses which you can make using a CT scan, and for some cases you need to do a biopsy. Transbronchial lung biopsy in that earlier case, because she had reticular nodular opacities, it gave a better chance of a diagnosis. But now transbronchial lung biopsy, as was shown by the previous speaker, is now replaced by a cryo lung biopsy. You don't need to do surgery, but through the bronchoscope you can do cryo lung biopsy and you can make a diagnosis. For this particular patient, this was the differential diagnosis, and we had needed why do we need a precise diagnosis? We discussed this earlier also. No more empiric therapy. As far as possible, we must get as precise diagnosis as possible, and whenever it is feasible, we need a histopathology diagnosis. And again, transbronchial cryobiopsy. These are the details. I'm not going to go into the details because they were already described earlier, but I want to show you a video about how transbronchial cryobiopsy is done. This is how it is done. You need a balloon, you need a cryoprobe, and then this can be done in the bronchoscopy room, in the endoscopy room. It has to be well equipped. I have an anesthesia, I've got a boils, we can intubate the patient, we can do a rigid bronchoscopy in these patients, and we can also do C-arm. So basically, it's not a regular bronchoscopy room, it has to be a well-equipped bronchoscopy room where you can give general anesthesia also. And then in this particular case, we could make a diagnosis of hypersensitivity pneumonitis. So again, I've shown you transbronchial lung biopsy, and now it has matured to a cryo lung biopsy, and that has allowed us to reduce the VATS biopsies because there's more morbidity, more cost involved with VATS biopsies. We move gears now. 58 again, a 58-year-old gentleman came to us. I mean, this is almost 15 years ago. We did this case, and this patient, clearly you see here, there's a left lower lobe patch there on the X-ray, left lower zone. And then for this particular case, as was shown earlier, CT guided biopsy was described. So we did a CT guided biopsy, and in the CT guided biopsy, it is necrotic tissue, no granulomas. Basically, it is a non-diagnostic. It's typically very surprising, but if you have a proximal obstruction, then the distal lung biopsy may be non-conclusive. In those days, PET scan was available. We had this is a high-profile patient. We were able to do a PET scan for this patient. So the PET scan now clearly you see here. You can see here there is the PET uptake is there in these areas here, and these are the mediastinal lymph nodes which are present. Now, how do you biopsy a mediastinal lymph node? Something is called a bronchoscopic needle aspiration. Bronchoscopic needle aspiration is done very simply. You use a simple flexible bronchoscope, the regular bronchoscope, which you can get at the, even in the third tier cities, easily available. You take a needle, you pass the needle through and through the airway here. Where is this gone? Yeah, cursor. And then you aspirate. If you have a neck lymph node, you do a fine needle aspiration. Similarly, you can do a needle aspiration of the mediastinal lymph node, and you can make a diagnosis. And this is how a bronchoscopic needle aspiration is done. Okay. Now again, I've shown you this in this particular case. Yes, we could make a diagnosis. Now again, things have matured. You were shown about EBUS. When the needle was put in the earlier case, you could not see where the needle was going. Now we do CT guided procedures, we do ultrasound guided procedures. So this is a bronchoscopic ultrasound guided procedure. And in this particular case, what do you see here? You can see the needle going here. Look at the second image here. You can see the needle going into the lymph node here. There's a pulsating blood vessel here. And under image guidance, you can be sure where you have gone in, where you have taken the, and from where the biopsy is taken. So this is the research we did. Now, we are celebrating 20 years of EBUS since we published the first paper, and very good to see that the first paper which we published is now standard of care. Yeah. So this is how EBUS is done. And that now we come back to the case which I showed you. That individual in whom the CT guided biopsy was not conclusive. And then if you see here, if it is showing here, this is a sub-centimeter lymph node. The lymph node is 8 millimeters. And in 8 millimeter lymph node also you can put in a needle and you can get a biopsy. And clearly this patient had adenocarcinoma of lung. And the important thing here is what? We could do immunohistochemistry. Even you can do molecular studies using EBUS samples. So these are the papers. I'm not going to go into the details. The message from these papers is that you can make a diagnosis of lymph nodes, you can do immunohistochemistry, and you can collect enough material also for biomarkers, because nowadays in lung cancer, it is not only chemotherapy which is given intravenously. About 35 to 40% of patients with lung cancer, if you do these biomarker tests, now will qualify for oral treatment, tablets or capsules treatment, and you can achieve that with this particular test. So these are the different ALK fusion, you can do ALK, EGFR, other biomarkers can be tested. You can do a 12 gene panel in the same EBUS sample and get a more precise diagnosis for targeted therapy. This is the paper which we've published using a 21 gauge needle. These are the good biopsies which you can get with EBUS TBNA, and that gives you enough material. And all these procedures are done in the endoscopy suite. Patients go back home. From entry to exit is 6 hours. Okay, so they are gone as a daycare procedure. This is a paper which we published, and we showed here that we've actually not shown here, we've reviewed that this is a very good modality for diagnosis and staging of lung cancer. Lung cancer, the therapies have evolved a lot in the last 10 years, and the survivors have also improved. Let's shift gears to something more simpler. We see TB. Somebody asked the question in the press conference about simple TB, complicated TB, and Dr. Nangia described about drug-resistant TB, also described about normal TB. And again, you don't want to do empiric treatment. You want precise treatment. So if you have somebody who's got these big lymph nodes here, depending on which geography you are, it could be a sensitive TB or a resistant. This is a patient who's got 45-year-old male, fever, cough, weight loss, received multiple antibiotics, no benefit, and we did EBUS for this patient, and we aspirated blood, pus, sorry, and it was TB gene X positive, and there is no rifampicin resistant. Culture shows pan sensitive. Patient responds very well. What's the big deal? Next case, 40-year-old female, diabetic, hypothyroid, multiple course of antibiotics. We do a EBUS for this particular patient, and it eventually turns out to be on culture grows to be MDR TB. So on the X-ray, you cannot say whether this is a sensitive TB or a multi-drug resistance, and that's where this technology comes to use, where you can make a more precise diagnosis in terms of TB. This is the first paper which was published, shows we published this from India 2019, and which the world first paper shows the utility of EBUS TBNA technique in the diagnosis of drug-resistant tuberculosis. So this is the value of this technique, and we know that TB is one of the most common infections in our country and can be utilized well. Again, moving gears, you were shown rigid bronchoscopy, foreign body aspiration is good. I just want to show you that using rigid bronchoscopy, sharp foreign bodies can be safely removed using rigid bronchoscopy. This is, root canal is happening almost. I think all of us will, like we get a cataract surgery, we might get a root canal surgery, so common. But that root canal screw can be aspirated, it can go into the lung, and this can be removed. It's a sharp thing, and rigid bronchoscopy is a tool which can be used to remove foreign bodies. Now this is the airway. Airway showing that there is a big obstruction there. Now you want to remove this obstruction. Patient got difficult in breathing. There is stridor. Okay, 23-year-old female. She's got weight loss, difficulty in breathing, hemoptysis. She's got wheezing as well. Now this I showed you is being done using an endotracheal tube. So if you do not have in that situation a rigid bronchoscope, and if you are trained well, you could also do this through an endotracheal tube. And look at this entire growth could be removed within 20 minutes using bronchoscopy. This turned out to be tuberculosis. Now, a lot of patients undergo ventilation, you do endotracheal intubations, you can get airway stenosis. Now, this is a patient, look at that small, this is the airway, okay, and this is our main airway, which is 14 to 16 to 18 millimeters in diameter, and this was hardly 2 or 3 millimeters. We can do balloon dilatation, and with balloon dilatation, we can open the airway. This is called as a balloon tracheoplasty. Again, this procedure can be done approximately 20 minutes, can be done in the endoscopy room, and we do this routinely. Look at this, that's a small stenosis, and you see this post balloon tracheoplasty. We can use now, suppose I showed you a TB obstruction, I showed you a foreign body removal, I showed you a narrowing, I showed you a removal of a mass which eventually turned out to be TB. Look at this. You can use lasers also. Does this work? Yes, it works. So lasers can be used to debulk. There are different types of lasers available depending on the institution. You can use laser, electrocautery, or you can use also a diode laser. And look at this, you can actually remove the tumor. This allows the individual to breathe well, okay, and gives a lot of symptomatic relief. Stent insertion was shown. If the airway is narrowed, okay, it's compressed from all sides. We know that stent insertion, we think about coronary stent insertions. Airway stent insertion is also useful and possible in select patients here. What you see here is one of the first stents we did using the Ultraflex stent in 2001. And, I'd like to show this video. Look at this. And the Ultraflex stent continues to be one of the better stents, metal stents in selected patients with lung cancer. And you see how the airway completely opens up. This is the paper which is published in Chest. We showed that if you use lasers, if you use stent placements, these individuals can have a good survival, and they can also qualify for good chemotherapy. In our setting, you can use a combination of electrosurgery and laser. This patient was offered actually a pneumonectomy. They were referred to us for removal of this lesion, turned out to be a carcinoid. And look at this, I'm now using electrosurgery. I'm not using laser. Electrosurgery is available in all hospitals. Okay, all hospitals, all OTs available. It's just a question about using the available equipment well. And here you can see here, this was removed. I moved this forward in the interest of time. Oops, doesn't work. It doesn't like that I move it. Never mind. So let's see. In interest of time, can I move this? Doesn't work. Anyway, so you can use electrosurgery in interest of time. I'll go ahead. You can use cryotherapy also to remove these tumors. Cryotherapy, I showed you cryo lung biopsy. Same technique can be used to remove tumors. Same technique can be used to remove foreign bodies also. Quickly, a few more, a couple of slides more. Now, this is a case of CA, advanced CA esophagus. This patient has got an esophageal stenting done. Mind you, esophagus is present behind the airway. If the esophageal tumor expands, if you put in a stent, it can compress the airway. Okay, and now after the esophageal stent and the esophageal tumor is expanding, patient comes with difficulty in breathing and comes with stridor. Look at this. I mean, there is a. I'm not sure if this projects here. But if you see here, this is the esophageal stent, and look at this airway. This airway should be big. This is completely narrowed here. And for this particular patient, we went ahead and we did what is called as a metallic stent here. A Y stent was put in here. This, I showed this paper. This is not my paper, but a paper published from India, which describes this technique good and this experience in a good way. So a Y stent can be put in, and you can almost create a new artificial airway. Let me show you a better illustration. 65-year-old male, small cell carcinoma, not responding to chemotherapy. You want to give radiation. This is the trick here. He cannot lie down. How he just cannot lie down to get radiation therapy. So what we did for this patient is, this is how you create an artificial airway almost. Okay, we put in a Y stent, open up the airway. The patient can lie down now, and now this patient qualifies. One is his breathlessness becomes less, and he qualifies for radiation. The point is, all these techniques are available, and we can use this appropriately in selected patients. Tracheoesophageal fistulas are very common. Okay, so tracheofistulas, you can put in a stent. I'll not go into details. You know, people can look up this paper. It's one of the largest series published using stents for airway fistulas. We published this some years ago now, and it shows that in fistulas you can use metal stents, sometime in the airway alone or in combination with the esophageal stent, to get a good relief for these patients. Fluoroscopy is a very important procedure. Is done for diagnosis of either a pleural effusion, or it is done for treatment of a pneumothorax. Okay, so quickly, I just want to take you through this. A 56-year-old female, she has adenocystic carcinoma of maxillary bone 4 years ago. Now she has cough, breathlessness, and effusion. 4 times tapping is done. She started on anti-TB treatment empirically. She's not responding. Okay, when there is a history of cancer, I think one should not start anti-TB treatment. Then she comes to us. Look at this, at 4 o'clock. I got a time here in the evening. Again, a repeat pleural effusions after 4 tappings. We put in an intercostal drainage tube, relieve of breathlessness, and now we want a diagnosis for this patient here. So look at this. This is a fluoroscopy which is being done. You see the intercostal drainage tube here. Multiple tappings lead to a lot of adhesion, so some adhegiolysis has to be done. You have to break the adhesions, and after breaking the adhesions, we find that yes, there is a tumor there. We take the biopsies there, send it for testing, and because after we are able to remove all the adhesions, the lung is expanding. Because the lung is expanding, we can also do what is called as a pleurodesis for this patient here. Look at this. This is the, remove all the adhesions. Biopsy is being done here. So we could find these nodules, discuss with the family that yes, this seems to be malignant, and we can save an extra procedure at a later date. And I'll show you after this. I'm sorry I can't forward this in interest of time, but now after this is followed by talc pleurodesis. So what we do is you spray talc over the lung and allow the lung to expand, and there's a pleurodesis which happens, and after the pleurodesis happens, it prevents the recurrent effusion. That's what's the role of pleurodesis. And look at these x-rays that follow up also. She got a lot of relief from the pleural effusion. Last case, and last 2 slides. Pneumothorax, middle-aged gentleman, non-smoker, 4 episodes of pneumothorax in 2 years. Every time ICD is inserted, and for 1 week, he's admitted for 1 week, lung expands and goes back, comes back after 6 months. This time he comes to us with the ICD. Okay, and what we did for this patient is, this is a fluoroscopy we did for this particular patient here. And if you see here, after fluoroscopy, we did a talc fluorodesis for this patient. And there were small blebs here. Those blebs were less than 1 centimeter. And if you have blebs less than 2 centimeters, you don't need to do anything. You can just go ahead and do a fluorodesis. If it's bigger, then you call the surgeon friends, and you may want to do some surgical procedure. What I show you here is if you can remove that timer, it shows we published the long-term outcome of the talc fluorodesis spontaneous pneumothorax. It's a safe thing. There are many concerns which people have, and I just showed you. This is where I work, and I mean, this shows 1974. I could find the report in my previous institution. The first talc fluorodesis using thoracoscopy. This is the report. Was done in 1974. It has stood the test of time over 50 years, and it is a safe procedure in selected patients. And this is that detailed the detailed paper which you can look up. This has already been discussed. Tunnel pleural catheters can be used for a trapped lung, malignant pleural effusions, recurrent pleural effusions. They've got a good role. And I think I will not go into the details of this. There are other techniques like navigation bronchoscopy, bronchial thermoplasty. I've got those slides here, but I think that's not daily clinical practice. Today's topic was daily clinical practice. I've shown you cases of daily clinical practice, and I hope this helps you in your practice and for the young students in their exams. Thank you very much.
Non-academic question.
Yes, sir.
Being a medical superintendent of Sasandala Hospital, bus का जो cost of making this bus in our facility we don't have. Can you suggest me how much the cost is going to?
So now this cost, I think if you allow me to say this, is a perspective. It depends with what perspective we look at it, because it's giving a diagnosis. I think as pulmonologists, somehow we have been limited. I say we, including me, have been limited in the vision and limited by the costs, etc. I'm not saying costs are not important, sir. Okay, costs are important, but then we have to look how much benefit a particular modality is giving to that particular individual, and for the individual, that's the world. If you give a precise diagnosis to the individual, I mean, it's his life for him. Okay, so I think that's one perspective. I will come to your perspective also about the finance. So I think we have to always remember a diagnosis. I think in medicine per se, I think diagnosis is the most important thing. I think the specialist, I think our job to make a diagnosis, treatment, ek baar diagnosis de diya, you go home and somebody else can also treat. That's not the point. Now, coming into a medical college, etc., the cost of EBUS. So I think, sir, it's not so expensive. You can say that 30,000, 50,000 expensive, but then you can also say it is not expensive. You have a one-time cost of the equipment, and I think the public institutions have got CT scans, they've got MRIs. You can justify that. You can justify a cath lab. You can justify robots. Why you can't justify an EBUS? 50 lakhs, 60 lakhs. I hope I made my point, sir.
In your institution.
Sorry, sir?
In your institution, this procedure,
Yeah.
how much patient has to pay?
Sir, I do this in a corporate setup, and the cost of the procedure in my setup, I think if you do on a daycare basis, is the procedure cost is about 38 to 40,000.
That's quite okay.
Yes. Of course, there are additional charges. There'll be anesthesia charges. There'll be lab charges. If the patient stays back, there are different charges. But I'm talking the cost of the procedure.
Doctor,
सर ये कॉस्ट है ना सर, ये इंस्टीट्यूशन पे डिपेंड करता है सर. अभी अगर आई विल टेल यू माय इन द मेडिकल कॉलेजेस they get the thing, then उनको needle cost आता है. You have to see what is the recurrent cost of the thing. So I think the cost, I just say, I think it is inappropriate to discuss the cost. I think what we need to do in academic meetings, I'm sorry to be more provocative and so strong, we need to discuss the benefit to the patient. I think that should be the focus, and I think we need to work out how we are going to, yes, some cost is there, how we'll work out and bring the benefit to the patient, I think. So I think it's a mental block. I've had it, and I think Vivek will also agree with it. Prabhu Desai is there. Where is sir? He's there. Prabhu Desai, you will also agree. I think the diagnosis is where, he's a man of tremendous clinical experience, and he will also agree. I think the focus is diagnosis, sir. Cost is a mental block. I'm not trying to be arrogant. I'm just using this platform to convey a very important thing which I learned over 20 years. Yes, sir.
Yeah, I enjoyed your talk, Dr. Prasad. I have few questions where we get involved as a surgeon in making a diagnosis, like staging for lymph node staging for lung cancer. So the question is, if you have the facility of PET scanning, surgical mediastinoscopy, and
Yes.
TBNA, which one you think
Yes,
is the best?
So the question is, if in a lung cancer staging, you have PET scan, you have mediastinoscopy, and you have EBUS available. One must understand that PET scan will only show you hot areas. PET scan will show you which are PET positive areas. If PET scan in a patient with lung cancer, if a PET positive lymph node or a PET negative lymph node, say if a PET positive lymph node was always cancer, and if a PET negative lymph node was always not cancer, then we would not need mediastinoscopy. A PET CT would replace tissue diagnosis, but that's not what happens. Whenever a PET CT is positive in a lung cancer patient, it can be reactive lymph nodes. We've seen granulomatous response to malignancy that can be PET positive, and we see that it's not uncommon. Often we get anthracotic lymph nodes which are not PET, which are PET positive but do not harbor malignant cells. So I think, and it can we get tuberculosis. So I think a PET positive lymph node should not be taken as malignancy positive, and I think we need to chase a PET positive lymph node. If it's a PET negative lymph node, we know in adenocarcinoma, you can get a false negative. If the lymph node is 1 centimeter or less, the PET is not so sensitive. In adenocarcinoma, it may be infiltrated, but can still be PET negative. So again, you need to sample the lymph node also. So I think the jury is clear. If it is a PET positive or PET negative, you need to sample. Now the question is, will you use mediastinoscopy or will you use EBUS now? Now, EBUS is something which I said is done on an outpatient basis or a daycare basis. I will not get into the cost because I think cost is a very sensitive thing. But we know that this mediastinoscopy, we know people who do it on a daycare basis, on a single day admission basis. But mediastinoscopy has certain limitations. One is the expertise available. You mentioned that if both are available, okay, mediastinoscopy cannot, you can't sample the entire mediastinum as far as the staging is concerned, because with mediastinoscopy only enlarged lymph nodes can be sampled. You're the best judge in that. You need modified mediastinoscopies to sample certain lymph nodes, and the hilar lymph nodes are out of question. So if you have hilar adenopathy, you will need some other technique. And the advantage of the EBUS is, in staging, we have to do systematic evaluation. You have to start, we don't just target lymph nodes based on what is seen on the CT scan or the PET CT. You have to go and start systematically. Hilar lymph nodes are seen, subcarinal are seen, paratracheal are seen, aorta pulmonary are seen, precarinal. So I think EBUS allows you to sample all the lymph nodes systematically, and I think that's the advantage of EBUS. So to answer your question, if EBUS is available and mediastinoscopy is available, EBUS is the first choice, and that's what Tata Hospital has also done. Tata Hospital has excellent thoracic surgeons, as you're aware. They can do mediastinoscopy, in the back of the hands, but they also use EBUS TBNA because it offers a more extensive and more precise staging opportunity.
So, if I make a statement that surgical mediastinoscopy, it can be done as a daycare procedure, so there is not much of difference hospital stay-wise. It is a gold standard for making a definite diagnosis. It is most sensitive, most specific compared to TBNA. And also, majority of the stages, I understand about the hilar area, you may not be able to reach, but 2, 4, 7, all these stations, you'll be able to, sample. That's not difficult.
Yeah. So in our paper, which we published with Yasufuku, and I think we discussed about the utility of EBUS in teaching. I think there are plenty of trials. The initial trials were done as a non-inferiority, so they considered mediastinoscopy as the gold standard, and then you did EBUS to show that it is non-inferior to mediastinoscopy. So the first trial showed that EBUS is non-inferior, and there are subsequent trials now which have clearly shown that EBUS is superior in systematic sampling of lymph nodes, because there are some lymph nodes which may not be seen on imaging. There may be a gap between the imaging and when you do the procedure. So I think, therefore, I think almost mediastinopathy is now being replaced by EBUS TBNA in, I think, yeah.
And another, because the very commonly we come in our surgical practice referred by the chest physicians, the patients they have the sort of loculated effusion or even empyema, and they are not, means they attempted, they could not get the pus out, or they put the chest tube, there is nothing coming out, those kind of thing. And when they get a CT scan or ultrasound, they find that there are loculated pocket of pus or collections. So in those cases, because if it comes to me, the first thing which I do normally, because I usually put that chest tube and try, once we are sure that it's in place, then we attempt that intrapleural fibrinolysis. So what do you think is the role of intrapleural fibrinolysis?
So I think the question is about using fibrinolysis in empymas and their loculated effusion. Yes, intrapleural, fibrinolysis does have a role, but I think the role is a selected role. I think it depends at what stage if the patient has come in early. I think at that point, if you put in a tube, and if it's not too organized, I think there is a role for intrapleural fibrinolysis. Typically, unfortunately, what happens in our practice is, we are not the first point of contact. Typically we would have patients seen by the at level 1, level 2, and the complicated cases land up with us. So what is my approach when a patient comes to me? I think if there is a empyema, there is a loculated effusion, there is multiplicated effusion, is a thickening of the pleura, I think it straight goes to the surgeon. I think the role of pleuroscopy in the endoscopy suite is mainly diagnostic. If you have a little bit of effusions, you can, a little bit of septae, you can do the adhesiolysis. But I think the the pleuroscopy we do in the endoscopy room does not replace the VAT switch you do, where you can do a more systematic decortication, you can do a more systematic, I think that helps more. So I think I'm very clear on this. As far as the, yeah.
Thank you.
Thank you very much, sir. So to present Momento and Angavastram to Dr. Prashant, sir, I would request Dr. K.K. Gupta, sir. Please, sir.
So we now have the Dr. Vivek Nangia, the Director and Head of Pulmonology, Max Super Specialty Hospital, New Delhi. We'll be talking on approach and management for undiagnosed TB in clinical practice. It's quite important to all internists, as Dr. Gupta said. We do have a lot of problems and still keep on coming. He is a chief pulmonologist, Cluster Max Hospital, Principal Director and Head Institute of Respiratory Critical Care and Sleep Medicine, and Vice President of IAB. 30 minutes for you.
Good evening, everybody. At the outset, I'd like to thank Dr. Pathak for inviting me here this evening. It's really an honor. In fact, last year also he had invited me, but I couldn't make it. This year, I have postponed my summer vacation only to be here with you all. So, which we start from tomorrow, which was actually to start last week, but we postponed it and planned it in such a manner that it starts tomorrow now. So, anyway, I think there's some connection loose here. But let me start with this. So, approach to undiagnosed tuberculosis. I was talking about tuberculosis earlier also in the evening. Tuberculosis continues to be a rampant infection in our part of the world, especially if you look at the WHO statistics for the global statistics. There are more than 10 million people suffering with TB, about 1.3 million deaths every year. This is 23 report. In 2022, there were about 1.3 million deaths. There's something wrong with the connection. Yes, हटाओ पहले नीचे से इसको. So this is the second leading cause of death from a single infectious agent after COVID. Imagine the number of deaths that we've seen with COVID, and this is the second leading cause of death around the world because of an infectious agent. More than that, because of HIV, HIV is so considered to be like a death warrant the moment anybody is diagnosed with HIV. On the contrary, it is TB which is resulting in more deaths than HIV does. And India continues to have the largest burden, contributing about 27% of the global incidence of tuberculosis comes from India. So more than 1/4 comes from India. And of course, the MDR TB is becoming more and more common. Globally, there were like 4 lakh cases in 2022. And in India, there are about 64,000 cases of MDR TB which have been notified. Now, with Nikshay coming up, the notification rates have gone up significantly in our country also. There are about 172 cases per lakh of population and about 24.2 lakh cases, which is a 13% rise from 2021 to 22. So, when do you really suspect tuberculosis is the first question that I'd want to ask you. Classically, anybody with a cough more than 2 weeks, fever more than 2 weeks, especially if it is low grade, evening rise, associated with night sweats, that is what classically would be the fever pattern in a patient with tuberculosis. If they have hemoptysis, if they have a non-resolving pneumonia despite a course of antibiotics, and any abnormality in chest X-ray could qualify for a suspicion of tuberculosis. And especially so in patients who have been in contact with a microbiologically positive patient, like a family, one of the members of the family who are positive for TB. People living with HIV, they are more prone to developing tuberculosis. Diabetics, malnourished people, cancer patients, patients on immunosuppressive therapies, especially nowadays with so much of all these disease modifying agents being used like MMF, rituximab. Tuberculosis is becoming very common. In fact, before starting rituximab therapy in any of your patients, you must evaluate them even for a latent TB. And if positive, then you may want to consider giving them an INH prophylaxis or an LTBI treatment. So let me start with these cases. Now, first case is of a 52-year-old male, chronic smoker, cough, phlegm, low-grade fever for 2 months, loss of weight for 3 kgs in 3 months, has Krebs in the right infraclavicular area. ESR is 118, MAN2 positive, HIV negative, sputum AB smear negative, and this is what the X-ray is. So what would you do? MAN2 positive, HIV negative, X-ray showing typical pattern in the right upper lobe. Would you want to start treatment or not? You would want to start treatment. CB-NAT. So basically, you could give these patients a trial of antibiotic initially, 7 to 10 days. But please be careful that you use something like an amoxicillin, like a cefuroxime, and not a fluoroquinolone or a linezolid. Both these drugs are very good antitubercular agents. We reserve them for our MDR TB patients and do not use them routinely in any of our patients. These drugs are completely banned from our unit, And we have never used a fluoroquinolone for our OPD patient or even in an ICU, unless you have proven beyond doubt that this is not TB. If you use any of these drugs, you're only delaying the diagnosis of tuberculosis by 2 to 3 weeks, because that is the time it takes for the bacteria to start showing up again. And then we need to remember that there is no role of all these inaccurate tests of IgM, IgG, IgA that we get done for all our TB patients. And even the IGRA has not been validated in India yet. So it is not recommended to be used for the purpose of diagnosis of tuberculosis. Now, as far as the features of tuberculosis on a chest X-ray are concerned, they can be wide and varied, starting with focal infiltration. It could be unilateral, bilateral. It could be airspace opacities with the nodular opacities, tree in bud appearance. It could be anything really. There could be cavitation, there could be enlargement of the nodes, small fibronodular opacities which are called miliary mottling on a chest X-ray, which you may need to confirm on a CT scan subsequently, or pleural effusion. The variety can be large. I mean, the options of on a radiological picture for a tuberculosis patient can be similar to anything else also, like a viral infection, like fungal infection, pneumonia, malignancies. So there's so many overlapping features. So you may get a CT scan done in these patients. CT scan also showed this airspace nodular opacities. Then what? Would you start the treatment or not start the treatment? You would still want to do a microbiological diagnosis for these patients. Why? Because it is important to know whether this is one, tuberculosis finally or not, two, whether this is drug resistant TB or not. Even in the drug resistant, is it monodrug resistant, polydrug resistant, MDR TB, XDR TB? Unless you know that, you should not be starting the treatment, at least making an attempt to reach somewhere near there, even if you're not able to reach a final diagnosis as far as the microbiology is concerned. So of course, simplest would be to send a sputum sample. 2 sputum samples sent together can within a gap of 2 hours can be sent. You could ask the patient to nebulize with a hypertonic saline and then collect the sputum sample and send it. Or a bronchoscopy is a very simple option. It just takes about 2 minutes going in, coming out under local anesthesia without sedation, and you have a sample ready to send, which has come from the depths of the airways. This is one study which is recently published from Korea, nationwide prospective cohort study, where they had some 5,000 patients, out of which so many were excluded from the study. 319 finally underwent bronchoscopy, and out of these 319, and these are all smear negative patients, AAB smear negative on the sputum, 50% of them could be diagnosed based on the bronchoscopic results. Of course, I'm not saying that every patient should be subjected to a bronchoscopy. Bronchoscopy should be reserved for patients who have an unsuccessful attempt to obtain the expectorated sample, negative sputum studies repeatedly, and yet the index of suspicion for TB is very high. Potential alternative diagnosis exists in your mind. Urgent diagnostic information is needed if the patient is critically ill. Then you wouldn't want to wait for the sputum report to be coming, but you would be sending the sample immediately. Then what is also important is once you've done the bronchoscopy, you've actually unsettled the lungs inside, patient coughs, patients sometimes bring out more phlegm from inside than you expected. So you can even collect the post bronchoscopy sputum sample and send that too. And then of course, what we've started doing now is also sending the tissue biopsies. You do a transbronchial biopsy, send one for histopathology and one for culture. Culture, AB smear, gene expert, all three are sent together. So the costs go up significantly when you do procedures like this, primarily not because of the procedures, but because of the lab investigations. But they are essential. They are essential to reach a definite diagnosis. How else would you reach a microbiologically confirmed diagnosis, which is now required for most of our patients, if not all? So a transbronchial biopsy would classically show you the caseous necrosis, which is classical of tuberculosis. And when you send the microbiological samples, you send it for AB smear, you send it for cultures. Cultures also, we believe in MJIT now. We moved away from LJ media. Then you put them up. Once the culture is positive, you get a sensitivity done. Sensitivity will tell you which drugs are best suited for this patient, whether this is rifampicin resistance or not. Other than that, you can even do the gene expert and the molecular studies, which I'll just describe. So as far as AIB smear is concerned, it continues to be a simple, inexpensive tool with a high specificity. Results are available quickly and correlates very well with the infectivity of the patient also. But the major drawback is that it requires at least 10,000 bacilli to be present in that sputum sample to be detected and reported as sputum positive. But the better thing is that as far as radiology is concerned, it's more specific and has less inter-observer variability. That means if two people are seeing the smear, the chances, and two people are reporting the X-ray, the chances that the diagnosis will match are higher when it comes to sputum than when it comes to a X-ray. Then we have rapid diagnostic tools that are available to us now. Gene Expert is one of them that we use very rampantly, and it requires all of 10 bacteria. The Gene Expert Ultra, which is now available for the last 1 year, requires only 10 bacteria to be present in the sample to be reported as positive. It has excellent positive predictive value, and the results are obtained from the unprocessed sputum. It doesn't require any processing to be done. This is a US FDA as well as a WHO approved modality of investigation. After this, so what is the advantage with Gene Expert? Gene Expert gives you one, it is positive. Second, it also gives you whether it is rifampicin sensitive or rifampicin resistant. Whether it is rifampicin sensitive or resistance, that should not hold you back. Once your Gene Expert is positive, you must get an XDR Gene Expert also done. First Gene Expert only gives you sensitivity against rifampicin. The XDR Gene Expert gives you the sensitivity pattern against INH, ethionamide, fluoroquinolones, aminoglycosides. So all four of the drugs, so you know exactly whether the patient has any other resistance or not. This is also recommended by WHO now, and almost like a part of our protocol now for any patient in our unit who turns out to be Gene Expert positive or smear positive, we get their XDR Gene Expert also done. The specificity is 98 to 100%, and most accurate results have been seen with INH and fluoroquinolone resistance. Apart from that, there are also line probe assays. Line probe assays are mainly done once the patient is sputum AFB culture positive. Once that is done, then they could do a Haynes line probe assay, Haynes 1, Haynes 2. And again, Haynes 1 would give you the sensitivity against rifampicin and INH, whereas Haynes 2 would give you the sensitivity against fluoroquinolones and the second line injectables. So collectively, you'll get to know about the entire spectrum, whether this is sensitive or a resistance AFB bacteria that you're dealing with. So coming back to our case 1, we had Gene Expert positive on the bronchoscopy, and we got the XDR done. XDR was also pan sensitive, so we continued with our HRZE. We had done the transbronchial biopsy also, which showed necrotizing granulomas. The bile and tissue AB cultures were negative, but this patient did well with the treatment that was started. Now coming on to our second case, 36-year-old female with low-grade fever for 2 months, mild dry cough, CBC within normal limits, ESR of 35, MAN2 negative. What do you see on the X-ray? Anything? So just some mild right hilar enlargement here, probably bilateral hilar. So we got a CD scan done. CD scan confirmed the presence of mediastinal lymph nodes. So what next? MAN2 negative, mediastinal lymph node positive. You would think of sarcoidosis. You get the ACE levels and all done. They're all normal. So what next? You basically have to form the diagnosis. For the extrapulmonary diagnosis, you may rely on the microbiological reports. Again, you need a sample from inside, whether that is for the AFB smear, culture, Gene Expert, all of them. But also, you would need a tissue diagnosis. So you would want a cytology or a histopathology to be taken and then correlated with it. So EBUS is a very good modality. It just takes about 30 minutes for the procedure to be done. Could be done under mild sedation, could be done under deep anesthesia depending on the patient's requirements and the patient's cooperation levels. This is being done for nearly 15 odd years or probably longer now, and the expertise is actually growing. You can do a rapid on-site evaluation as we do in our hospital, which is called ROSE, and the diagnosis is available within minutes. Even before you end your procedure, you know what you're dealing with in some cases. The cytopathologist or your own well-trained pulmonologist can actually sit and see the slides and tell you while you're doing it. And as far as the lymph nodes are concerned, there was a discussion going on prior to this. EBUS can easily access the stations 2, 4, 7, 10, 11, 12. The EUS BFNA, as we call it now, endoscopic ultrasonography with bronchoscope FNA, which is done through the esophagus, can also access paraesophageal lymph nodes at 8, 9, 3P, and of course subcarinal node can easily be accessed by that also now. And the diagnostic yield goes up till 68 to 87% and sensitivity is 45 to 95%. And for lymph nodes which are beyond the vessels, in expert hands, you can even do a transvascular needle aspiration. The needle accept has to be very fine and the stroke has to be very gentle when you're puncturing the vessel. But then you need to have that expertise to be able to do this. From just needle aspiration, we've started doing transbronchial cryobiopsies also now from the mediastinal lymph nodes. This is a video of that where you can see initially a transbronchial needle aspiration is being done from the lymph node, where we are puncturing the lymph node repeatedly with the needle and taking the aspirate. After this, we take out the needle and just puncture that site again 2-3 times to widen it a bit. Once that's widened, then you put in a 1.2 mm cryo probe into the lymph node and can take a biopsy. People have also inserted the usual conventional biopsy forceps into the lymph node and taken a biopsy for a better yield. Again, it's all about the size of the tissue that matters. The amount, the quantity of sample that you're sending to the lab will be directly proportional to the better result that you will get. And as Dr. Prashant also said, what is important is to get to a diagnosis. These are patients who are troubled because of their fever, because of their symptoms, and are not reaching an answer. Sometimes all you get is just some reactive lymph node. You may get some just granuloma there, but is that sufficient? That doesn't help you reach a diagnosis. There can be several granulomatous diseases that could be resulting in this kind of a lymphadenopathy and fever. Therefore, when you collect the sample, and this is not a procedure that you can repeat so often. So when you take the sample, you send it for everything possible. Cell count, cytology, your cell block, microbiology, cultures, AB smear, gene expert, everything is sent in one go itself. So this is the cryoprobe which has been inserted. You can see this, the tissue is then frozen and pulled out. It just about 2 to 3 seconds is all that it needs to be frozen for, and you pull it out and you get a very good sample. So it's less invasive than mediastinoscopy and vast lymph node biopsy. It takes you beyond the cytology or cell block and gives a much larger volume to get you a better diagnosis and of course an adequate sample. So in our case too, we had the BAL AB smear, gene expert AB culture all negative at 6 weeks also. EBUS ROSE was done and it showed only a reactive lymph node, but we did the EBUS TBNA which showed occasional granulomas and gene expert was negative, but then the AB culture turned out to be positive at 3 weeks, and on drug sensitivity it was sensitive to all. The EBUS cryobiopsy confirmed the presence of necrotizing granulomas, and TBNA culture was positive at 3 weeks. Yes. Now coming on to my third case and the last case for the evening. Now we look at the pleural effusion, which can be again very challenging at times. 60-year-old male diabetic, right-sided chest pain for 1 month, dry cough and shortness of breath with an absent air entry, and this is what the X-ray looked like. Had undergone a diagnostic pleural aspiration before coming to us with proteins of 4.2, sugar of 100, LDH 682, ADA 22, lympho predominant 75%, and malignant cytology was negative. So what would you do in this patient? Start ATT or not? The features are classical of TB. No, not start ATT. Then do what? Then do what? Sorry? Cell block was also negative. So what do? This is what brings you to the concept of medical thoracoscopy, a procedure which is done by the pulmonologist in the bronchoscopy suite itself with hardly any costs involved. It can even be done bedside, it can be done in the ICU, it can be done with the patient sitting up. It does not require any general anesthesia, just low, mild sedation, much cheaper than a VATS procedure for diagnostic. So I'm not comparing VATS versus medical thoracoscopy. I'm comparing medical thoracoscopy in an undiagnosed pleural effusion versus VATS in an undiagnosed pleural effusion. Otherwise, thoracoscopy and VATS have different indications altogether. So when you do this, then the chances of reaching a diagnosis become much higher. Just with a simple needle biopsy, the chances are 51%. When you do the cultures, 28% adds on, collectively 61%. When you add medical thoracoscopy to it, the chances are that 99% you will reach a diagnosis, and you combine it with the culture of pleural fluid, 100% that you will reach a microbiologically confirmed diagnosis. Why do I say that? There are certain very typical features that you get to see when you do a thoracoscopy in a patient with tuberculosis. If you see something like this, see these thin fibrinous bands, those small little nodules, loculations which are very thin, not thick. They're classical of tuberculosis. You see this and you know it is TB and nothing else. If you are able to break these adhesions, then they are tubercular. This is a classical loculation. You puncture it and the fluid comes out. You take a tissue from, take a sample from these adhesions and send them for culture. The chances of getting a culture positive from this fibrinous adhesion is higher than that from the pleural fluid. So we always take these tissues and send them for cultures of our patients. So this is like a spot diagnosis that there is confirmed TB. Now you only need the microbiological confirmation. So you take as much tissue as you want and send it all for cultures. And also it provides you the opportunity to break all these thin adhesions and prevent the patient from developing a fibrothorax subsequently. So Sago-like pleuritis, miliary granulomas, grayish-white blanket, and thin fibrinous adhesions are classical of tuberculosis. This is another patient. But then the quest for more and more is never ending really. You always want more sample, more tissue. That is why now we moved on to cryobiopsy from the pleural space also. Because you have to reach a diagnosis, especially in patients where there's a dilemma that it may be tubercular, it may be malignant, like this patient for instance. There was this single nodule there. So how do you ensure that you get a good sample? Of course, you do take biopsies, but then you want more tissue for confirmation sometimes. So you take a cryobiopsy now. This is a conventional biopsy from that nodule. Let's try to forward this a bit. So this is the cryoprobe being inserted into it. Just put it there, attach it to the surface, freeze it, and bring the tissue out. It's just so simple. So simple. It doesn't take longer than 5 to 6 seconds and you're out of it. So in our case 3, we had a pleural tissue which was gene expert positive, rifampicin sensitive. We did the XDR gene expert which was INH resistant and also fluoroquinolone resistant. So that is the whole advantage of doing a gene expert, which gives you INH resistance as well as resistance to fluoroquinolone's aminoglycoside. So you can actually, this one report, change the entire line of treatment for this patient. Otherwise, the patient would have continued to receive HRZE, and landed up in complications subsequently. The AFB culture of course pleural tissue confirmed necrotizing granulomas. So, my friends, I would like to summarize my talk by saying that, it is no longer the era of treating a patient of presumptive tuberculosis with just ATT randomly. We must make a sincere effort with all the armamentarium that is available to us now to reach, at least make an attempt to reach a confirmatory histopathology plus a microbiological diagnosis before starting a patient on antitubercular treatment. Especially when you're dealing with extrapulmonary tuberculosis, it becomes even more imperative to get at least a histopathological sample and microbiological diagnosis before you can start them on treatment. Thank you so much for a very patient hearing, and thank you for inviting me to see.
Is it? Yeah. Thank you, sir. Nice presentation.
Thanks.
I have three small query because we represent a still community which is extremely poor, hardly can afford anything. Now radiologists have become non-committal. If you look at the X-ray report, it's totally they leave it to the physician for altogether different reason. How frequent you see basal lesion? Because traditionally apical lesion, fibrosis, trachea pulling, conventional you start in tubercular. I'm talking to Dr. Rajendra Prasad also. We have been taught before also. The extra pulmonary manifestation of tuberculosis always is either post-primary or progressive primary. It's not the primary complex. In that context, how frequent you see basal lesion and you did the procedure and you got the confirmation that it is a tubercular? Number one. Number two, somehow TB gold has become very popular among the general physician. I don't know from where it came, but everybody wants TB gold. Where does it stand today in that perspective? And last is the ADA. In spite of protein very high, you get the report high lymphocyte count, ADA remains on the lower side. So these three queries for general physician who hardly have chance to get into these procedure and get the response.
Right, sir. Thank you so much, sir. Very valid questions, all three of them. The first was about, okay, let me start from the third question then first.
TB gold.
TB gold. TB gold is a very non-specific test. As I said, TB gold only reflects the latent tubercular infection. It does not relate with an active tubercular infection. The only situation where one would use TB gold, as far as we are concerned, would be once you've ruled out or done the entire investigative workup and not reached any confirmatory diagnosis. That is when you may consider using TB gold as your only ray of hope of reaching the diagnosis and starting the patient empirically on treatment, but not until you work the patient up exhaustively, completely, that you are mentally satisfied, patient is mentally satisfied that yes, everything has been done, and that too after taking the patient into full confidence. Because latent TB, every third individual in India has a latent TB positive. If you were to do their quantiferon gold or TB gold or a Mantoux test, it would invariably be positive. So you can't really start somebody on treatment for that. So first question was about basal involvement of patients with post-primary tuberculosis. So the teaching is that the primary tuberculosis happens in the upper lobes. Post-primary tuberculosis, which classically happens in adults, happens in the superior segments of the lower lobes. In diabetics, immunocompromised patients, you could get a lower lobe tuberculosis also. HIV patients, diabetics, those on immunosuppressive therapies, cancer patients, they could develop tuberculosis in the lower zones also. And third was about ADA, sir. ADA again is a good tool if it completely fits into that picture. There is no one single report that you can rely on when you're forming a diagnosis of an effusion. You have to look at the holistic picture. The cell count, the LDH, the ADA. ADA could be high even in an empyema. A low ADA definitely merits further investigative procedures like medical thoracoscopy. But an ADA in the range of 45 to 75, with an LDH in the range of 600 to 700, with lymphocyte predominant exudative effusion, there you are safe in diagnosing it as tuberculosis. But other than that, you have to think twice, you have to work up the patient further before reaching the diagnosis of tuberculosis.
That's the real brilliant answer for most of the questions for internist. Any other comment from the audience?
There can be, sir, certainly. Endobronchial tuberculosis can present with sputum positive, X-ray negative. Plus, also X-ray will be non-specific. Unless you get a CT scan done and say that radiologically there is no involvement of the parenchyma. Yet, patient could be positive when there's an endobronchial tuberculosis. We've had patients who are being treated as asthma. Young girl, doctor herself, just finished her internship for 6 months being treated as tuberculosis, so as bronchial asthma because of her wheezing. When we did her bronchoscopy, when she came to our hospital, we did her bronchoscopy because her wheeze was not settling, despite all the steroids, bronchodilators, did her bronchoscopy. There were extensive involvement of the tracheobronchial tree. She had developed a right main stem bronchial stenosis by now, an AIB smear positive, gene expert positive, rifampicin sensitive, started on ATT. She just came back. I mean, of course, she was on regular follow-up, but recently got admitted after almost a year now of her treatment. Absolutely well, no wheezing, even the bronchial dilatation has improved. We've had to do the ballooning for her to dilate the right main bronchus. And she's not one patient. We have 4 or 5 such patients with just endobronchial tuberculosis resulting in right main stem bronchial stenosis.
Dr. Prashad, you can have this mic.
So as I said, I've seen about 5 patients so far. Very few. Very small percentage, but yes, anybody with persistent wheeze, asthma not settling, should be investigated for endobronchial lesions. Absolutely, sir. That's what I said. Bronchial adenoma, carcinoids, tumors, cancers. So anybody with a persistent wheeze which is not settling must be investigated, even if on the X-ray looks normal, even if the CT scan looks normal, because those minor bronchial stenosis may just get missed on a CT scan.
Thank you, Vivek, for really telling very nice thing. And 2 things I would like to react to your question. One was the radiologist opinion about the X-ray. Sir, I must tell you, when I became faculty in 80s, when I used to teach TV and radiology, I used to tell there are certain findings which favors tuberculosis. But now, after about 45, 46 years, if somebody asks me, what is the lesion in chest X-ray which favors tuberculosis, I'll say none. Any lesion anywhere could be. That's why that I'm not defending the radiologist, but radiologist just imagine yourself. About the localized wheeze, what Dr. Ansari is my senior. When I was JR1, he was my senior resident.
Okay.
Those days was known as chief resident. I'm talking of 70s again. One of the localized wheeze I saw, one of the very important, one of my professor, he came to me a fine morning कि राजेंद्र वो मेरी सांस कुछ आज सुबह से फूल रही है हल्की हल्की. तो मैंने कहा सर आपको तो कभी मैंने देखा नहीं, कभी आपको कोई हिस्ट्री अस्थमा की, मैंने सारी पूछी तो बोले नहीं ऐसा कुछ नहीं. तो मैंने कहा कि भाई ठीक है इन्वेस्टिगेट, हमने कहा एक एक्सरे तो आप करा ही लीजिए. तो ही गॉट एक्सरे डन. तो एक्सरे में एक टूथ दिख रहा था. And that was and on the examination only one finding was there was a localized
monophonic wheeze.
Monophonic wheeze. So I said sir एक्सरे करा के तो देख लेते हैं. तो मैंने कहा इसमें दांत कैसे जा रहा है, दिख रहा. तो उन्होंने अपना मुंह खोला, उनके पास गोल्डन, बहुत सीनियर प्रोफेसर थे, गोल्ड का वो लगा था. तो बोले यार वही चला गया. So sometimes what I'm trying to say, foreign body does not always tells you that it is foreign body. I can narrate you hundred of stories, but this is one of the story which I remember. So localized wheeze is also a very important in clinical examination. You should never ignore it. Try to investigate. Thank you, sir.
Ji, sure.
Sir, my question is about the granulomatous diseases. The most commonly we are getting the sarcoidosis and the tuberculosis. So most of the findings are same in the both of diseases. Only thing which I experience, sir, that if we are lucky and we get the microbiological confirmation of the tuberculosis, at that time I am 100% sure that we are dealing with tuberculosis. Otherwise, I always in a dilemma whether we are dealing with tuberculosis or sarcoidosis. So, what is your, sir, your experience on this?
So very good question. In fact, this is a dilemma that we face very often. And just recently also we've had one such patient where despite all extensive workup, we could not find anything. And ultimately that is the time when you start telling the patient that there's so much of overlap between sarcoidosis, tuberculosis. These are the limitations of medicine. These are beyond our control also. We've sent everything possible and still not been able to reach a diagnosis. Well, yes, that happens, but not very often, rarely. And that is when the role of your IGRA, your MANTO, your ACE levels comes into play. You try and correlate. So, you put the entire picture into, you have a holistic kind of an approach, put the various things into one single puzzle and try to solve it for yourself. So there you'll have to rely more on a clinical sense and probably start them on a combination of ATT with steroids, with the with the with patient being warned about it, that how you'll fare, it's difficult to say, but yes, this is one situation where you're totally at a loss.
Thank you, sir.
Sir, I have a just a practical question which we come across very often in the clinical practice. So, what I learned from your talk is that do the gene expert tells you only about the rifampicin resistance, but doesn't tell you about the rest of them. So, the somebody who has been started on ATT by anybody, uh, based on just the gene expert report, which was positive and did not show rifampicin resistant, and he had a 4-drug combination which he ran for 6 months or 9 months. But you're not sure whether the means INH was really he was sensitive or resistant to. Now, in this kind of scenario, when you stop the ATT, because you guys do that very often, because this is in your clinical practice. So, what are the precautions you take? Is it just you go by the duration that he has finished 6 months or 9 months or whatever period you want, or you do some test as well just to make sure that he doesn't need ATT anymore?
So basically, you would do a radiological follow-up also of these patients as well as sputum follow-up of these patients. Of course, the National Tuberculosis Program does not say that. They only look at the sputum reports at 1 month and 2 months, and if those are negative, then they just complete the 6 months therapy and stop that. But from when you're doing it in your private practice, then of course you ensure that radiological clearance has also happened, or at least if not clearance, then radiological stability has been achieved over 2 months. Only then you would discontinue the treatment. You may extend the treatment from 6 months to 7 months. The other thing is, because of this monodrug resistance to INH, that is the reason why now in the continuation phase we give 3 drugs: rifampicin, INH, and ethambutol. That in case there is INH resistance, that would also be taken care of by the other 2 drugs.
Thank you.
Thank you.
We wind up the session because we are still behind the schedule. But
Thank
it's
you.
wonderful presentation and the clinical correlation.
Thank you very much, sir. So to present Memento and Agavastram to Dr. Vivek Nangia, I would like to call Dr. S.K. Pathak, sir. I also request Dr. S.K. Pathak, sir, to present Memento and Agavastram to chairperson, sir. Sure, okay. लगाओ 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 ऊपर
अच्छा वो ये वाला
This one?
तो डायरेक्ट ओपन करो उसमें कैसा है से कुछ है क्या तुम्हारे पास सकता है और
Thank you very much, sir. Moving towards our second session, I would like to call for chair Dr. Amit Johari, sir, Dr. A.K. Singh, sir, Dr. R.K. Sharma, sir, and Dr. Prashant Chachar, sir. अभी किसका लगेगा राजा कर वही तो डॉक्टर
Now, इनका नाम बदल दिया है. Now our speaker is Dr. Prahlad Prabhudesai. Actually, it is written wrong. Yeah, and his topic is newer treatment studies in asthma and COPD. Dr. Prabhudesai is the consultant chest physician at Lilavati Hospital and Research Center. He has published 63 publications. He has written a book on community-acquired pneumonia, a TED book on controversies in COVID pandemic, and he is a postgraduate teacher for DNB in chest medicine. Now, Dr. Prabhudesai, please.
Thank you at the onset, Dr. Patak. Thank you very much for inviting. And we had a wonderful session on predominantly on the interventional pulmonology diagnosis. We are going to discuss a very simple day-to-day activities, so day-to-day management disease called airway disease, asthma and COPD. Just would like to know how many of you are physicians here and chest physicians? Yeah. So asthma and COPD is bread and butter, and we always manage that very well. I know most of our Indian doctors are managing asthma very well, and including COPD, because there are a lot of drugs which are available now for us in managing this disease. And as well as the newer treatment strategies is concerned, obviously the guidelines have been given for asthma. GINA guideline is there, and for COPD, GOLD guidelines. So there are always changes which happen in these guidelines every year, and some changes are very important, which changes our concept of managing, and we should always try to track these guidelines so that our prescription will change and our patient will benefit. So you are all aware that asthma is very prevalent, and almost 2.05% of our patients are asthma. As well as prevalence is concerned, more than 17 million patients are there. And if you see the overall the global trends, if you see, okay, almost from all over asthma, 13.9% of asthmas are in India. And they are obviously there is a much higher, 3 times higher mortality and 2 times higher dailies compared to the global population. So we, despite being medicines being available, okay, our outcome of our patients is not good. Same way COPD, which is considered as a silent killer, because you can say that as per the goal, 50% of the cases of the in respiratory diseases in our countries are COPD patients, and more than 90% of the COPD related deaths occur in low and middle income countries. So in India, it is a second leading cause of death, disability adjusted lively year. So COPD is considered as a most common disease as well as airways concern. So how many of you feel that COPD and asthma are more or less similar, or there is no need to differentiate asthma and COPD in practice because the medicines are more or less same? So I would like to know from audience, how many of you feel that we should try to differentiate asthma and COPD? How many of you don't feel that there is no need? So most of the people are not commenting actually on whether it's really required or not. But yes, of course, if you see, the problem is because the definitions, if you see asthma and say both are chronic disease, both have got similar complaint, both are inflammatory disorders, and in COPD is asthma is basically airway disease predominantly, large airways, but in COPD it is a smaller airway disease, and alveolar also get involved in that. So this is the difference, and the reversibility component that, is there is a variability is there in asthma in airways functions are concerned, while in COPD is always persistent and progressive airflow obstruction. So there is a difference between these things. And this is the pathology in asthma. Mast cells are very important over here, and you have eosinophils. You can get neutrophilic asthma also, but most important cell which is seen over here is mast cell. While in COPD, you don't see mast cell. Okay, and you see neutrophils predominantly. You can have some amount of eosinophils, but there is a destruction of the alveolar wall can happen. Mucus impaction is also there, and there is some amount of fibrosis can develop. So there is difference in COPD and asthma, but there are some similarities. That's why the Dutch hypothesis, they feel there is actually there are a spectrum of one disease only. In asthma, you have got eosinophils predominantly, but yes, you can have a neutrophils also, and COPD has neutrophilic predominance, but there is eosinophils also. The response to bronchodilator is significant in asthma, but in some COPD is lesser. But there is a part of COPD where you can have some amount of reversibility. But see, the almost 40% of the COPD patients can have this variability, and sensitivity of lung function test to show reversibility is just 44%, and specificity is 72%. So this is something which creates a doubt whether we are dealing with the more or less similar disease. But there is a strong British hypothesis which says these are both are different, and airway inflammation is different, immunological status is different, area of involvement in the airway is different, trigger factors are different, and response to bronchodilator is there, and impact of inflammation is systemic means the in COPD you get involvement of other organs which asthma you generally do not have. So both are different disease, and there are sometimes you may have some overlap or some combination, or two diseases can exist in one patient. Okay. So let's see what GINA guidelines says about changes. Okay. First of all, everybody knows that asthma is a clinical diagnosis, which is the first time you can say that importance of spirometry is been put by the GINA. Okay. At some stage, if you have doubt, you must do a spirometry, or if not possible, the peak flow meter. And both are very important to diagnose asthmas. And you also should, when you're treating asthma, you should always try to find out, is my patient having asthma adequately controlled or not? and for that we have to take up efforts to find out asthma control is there, exacerbations are not happening, the trigger factors, etc., and all that. Okay, we also should try to see, because there are patients who can go into remissions both on treatment or without treatment. So that is also an important part we have to study. And we always used to think pheno is something which is used for diagnosis of asthma. So Gina says no, pheno is for only diagnosis of severe asthma. Okay, so this is something which is different, and this is the Gina guidelines, which if you see very carefully, which the first, the track one, what they call now, okay, is the older way of managing the asthma, where they should talk about budesonide and formoterol as a combination therapy for maintenance as well as for the exacerbation. And this is the steps which are given: step 1, step 2. As the severity increases, the dosages increases. Okay, and step 4, you can add anticholinergics, you have steroids sometime, and you have biologics role. What is this track 2? That this is a new thing. Okay, so it is not always that budesonide and formoterol should be used, but the basic principle is that whenever you are using a bronchodilator as a treatment in asthma, it should be always associated with the ICS. That's a very important statement. You can use short acting beta 2 agonists along with inhaled steroids, need not be formoterol and budesonide. And as the severity increases, dose we can increase. But when it goes to step 3, here you cannot use short acting, but you have to add for control LABA and ICS. That's a very important thing. And the dose increases. As a reliever here, you can use ICS and SABA. See, as a treatment of asthma, you can never use only single bronchodilator, but it has to be along with the steroid. That's the whole basic principle. And as severity increases, you should use a LABA, either as a formoterol or salmeterol. But remember one thing: the advantage in difficult cases, the formoterol with a steroid inhaler has got a better advantage over the other inhalers. So whenever there are difficulties are there, shift to this budesonide and formoterol combination, because asthma control becomes better. So this is what is a change over here. And but you can use beclometasone with formoterol. Earlier they used to say only budesonide. One more change which has happened over here is that leukotrienes, which we are rapidly used to use, there is a warning of the leukotrienes inhibitors. So combination of levocetirizine and montelukast or montelukast alone for longer is not being recommended. Okay, because of the neuropsychiatric complications which can have developed. LAMA, that is a long-acting muscarinic agent, as we called as an anticholinergic, should be added before we have to use oral corticosteroid in the advanced asthma, that is step 3, step 4 and step 5. So we add your LAMAs, okay, in this advanced disease. They also mention about allergy immunotherapy has got a role to play in severe asthma when we talk about biologics. Okay, and first time, we all know that COPD rehabilitation has been given. First time they mention that in asthma, pulmonary rehabilitation has got a great role to play to improve the quality of life. So remember these changes which are there, which are happening. And they have given us, ICS has given now, Gina has given you freedom to of various steroids. This is very interesting, which were earlier not given. So you can get beclometasone, budesonide, cyclosonide, fluticasone, all steroids can be used. And these are all ICS LAVA combinations can be used, which were not earlier. And but the MART therapy, what we call as a maintenance and reliever therapy, here only ICS and formoterol has been used. So this is very important. If you want to use as a MART therapy, you cannot use salmeterol, fluticasone or other trick. You have to use the ICS and formoterol, because formoterol is a short as well as long acting, and the ICS combination is good so that the complications of bronchodilator will not happen, asthma will get better control. So this is something which is very important. And when we are treating this patient, there are certain factors we have to look for
which we call as a risk factor, and we try to modify the risk factors. Okay, by exacerbations are there, tobacco exposure there, and there are various. Low lung function is a risk factor, remember. So in asthma, if you find a lower lung function, though patient in asthma is getting, you feel they are getting controlled, but it's a risk factor and the treatment strategy has to be changed. Similarly, obesity, the major psychological problems the patient has, major socio-economic problems, food allergies, occupational exposures, and the other sputum, eosinophil, etc. If they are there documented in patient who is not responding to asthma treatment, then these are the patients need a treatment strategy which is changed. Now, what is difficult to treat asthma and severe asthma? Before we say that my patient is not responding and we are considering this is stage 4 or step 4 therapy, disease, that is severe asthma or the asthma which is not getting adequately controlled, we must understand there is a condition, there is a this thing called difficult to treat asthma concept before we say severe asthma. So in difficult to treat asthma, your diagnosis has to be, because patient is not responding to your best line of therapy, okay, including higher dose of inhaled corticosteroids, LABA and SAMA and everything you added. Then you have to look for the diagnosis first. Correct diagnosis there or not, or something else. Look for the comorbidities which can aggravate the asthma. Third, adherence to therapy, which you cannot depend on only on patients. Okay, you have to have some active role over there. Third, fourth important, techniques. You have to go back, and I can tell you that 50 or more than 50% of the patients do not follow proper techniques. So then we consider this is as a severe asthma, and hence that severe asthma has to be managed in a different way. And this is the step 5 asthma. So where oral corticosteroids is easy answer, but remember oral corticosteroids gives lot of side effects. Biologics have got a greater role to play. Though they look expensive, long run they turn out to be cheaper because steroids gives plenty of side effects. Okay, and even more than 3 courses of steroids in a year leads to side effects. Okay, and then I don't want to discuss the side effects, but you are all aware of the side effects of steroids. And when such patient happen, do not manage yourself, refer to asthma specialist, because they will understand the endotypes, biomarkers which are respond for difficult asthma. And this is a very, very important aspect. Every chest physician should read about this and try to understand the endotypes of asthma. And there are various biomarkers, eosinophils, IgE levels, which can guide us regarding what sort of a biologics we can use, because this is the best chance. We can't change the biologics so easily. So try to select your biologics by the understanding your eosinophil count, IgE levels, and then we have a anti-IgE, omalizumab, we have mepolizumab and benralizumab, and now we still don't have the other, but yes, the last one, which is anti-TSLP, is likely to come, which has been approved and which can also change overall concept of all airway disease, which includes asthma, neutrophilic asthma, eosinophilic asthma, and also COPD. Okay, so now let's see from after asthma what changes has happened in COPD management. You are all aware that COPD is the most common disease, and our prescription has to change if there are, gold says there are a lot of changes which are going to happen in the future. So let's see how we can help our patient to get a better treatment for COPD. What Gold has told us now, that there are new updates have come on COPD, pre-COPD and PRISM. Let's see, we come to that. Screening of COPD in a target population we should do. See, if patient is having no symptoms of COPD and there is no risk factors, okay, there is no need to do any preemptively lung function test to diagnose COPD. That's a very important statement. Otherwise, all health checkups we try to give COPD diagnosis is not required. Okay, screening of COPD target not required. We also have to look for interstitial lung disease in COPD, because if you see chronic smoking, pollution, both are responsible for interstitial lung disease, and they have an overlap. And many times you may not be able to differentiate on plain simple X-ray or even lung function test. Okay, so vaccination updates have come. That's very important because earlier we used to have only flu vaccination, pneumonia vaccination. Now there are many vaccinations coming, and the managing the COPD with inhaler therapy, there are some new changes. Okay, as well as the proposed taxonomy of COPD is concerned. Alpha-1 antitrypsin is not very common in our country, but yes, you should do in a difficult conditions. But most important thing which changes have happened that COPD is not of elderly people and young people, but there is a good chance that COPD development can happen in the young children. So our children who gets recurrent infection, their asthma doesn't get controlled, or there are some reasons by which the children are suffering, they have a lower lung function, and these are the patients going to get later on COPD. So just like smoking, air pollution, third important aspect is now childhood infection or childhood poor lung function. That's an important thing. Okay, so biomass exposure, we are all aware recurrent infection, COPD, asthma, overlap and all can happen. But this is a graph which is very important to see. If your lung functions are poor, you have got in a young age, as a child, because of infection, your lungs are getting weaker and weaker. And when they become adolescents or adult, the lung functions remain lower. These are the patients who are going to get COPD. So pre-COPD is something which you are aware that there is a lot of relevance to the possibility of COPD, asthma, air trapping is there, emphysema is there, but lung functions are normal. They are not falling into the definition of COPD. Prism is the other thing where FeV1 upon FVC ratio is good, more than 0.7. Okay, but the FeV1 values, the spirometry is impaired if the absolute value of FeV1 or even FVC. So these are the patients. Not all develop COPD, but some of them develop COPD in future. So we have to watch these patients. This is very important thing which is there. Can you remove this? So now, what is the diagnosis of COPD? Lung spirometry is very important over here after clinical assessment. And FeV1 upon FVC post bronchodilatory, if it's less than 0.7, then gold gives guidelines or for gold 1, gold 2, gold 3, gold 4 as per the FeV1. And then management point of view, spirometry doesn't come into the picture. Only two important things come: symptoms. If there are more symptoms by CAT score, then patient goes into B. And if there are more lesser symptoms, they go into group A, provided they have got lesser amount of exacerbation, 0 to 1 exacerbation. So exacerbation and symptoms give this very beautiful picture of ABE. And our COPD should be managed not by spirometry here, but whether my patient is symptomatically improving, whether symptoms are more, CAT score and exacerbation. After that, exacerbation has been given extremely importance because as patient develops exacerbation, their lung function start falling and they become more sicker. So this is very important thing, and the treatment is very clear about that. In group A, only bronchodilators. Group B, long-acting beta agonists and LAMA. And if patient is in group E, then you have got LAMA and ICS if eosinophil count is 300. This is a very simplified way. So your eosinophil count is also very important. So when you do an eosinophil count, when patient is off steroids, not taking any steroid, you should measure the eosinophil count, or you should go back to the patient previous eosinophil count and see what is the eosinophil count, and then that will decide the steroid should be added in COPD or not. So strong indications for steroid is more than 2 exacerbation or history of severe exacerbation, or blood eosinophil count more than 300, and history of or concomitant asthma is there. Against use of inhalers is repeated pneumonia, history of tuberculosis. In our country, TB is very common, and blood eosinophil count is less than 100, where you should not use steroid in COPD. Beautiful guidelines. And then if on treatment, if your symptoms are more or exacerbations are more, then we decide the change in the line of therapy. Okay. So consider here, if the dyspnea is more, then we can add drugs. Okay, and if the exacerbation are more, then we add inhaled steroids as a combination. If you see here in this group, you have got LABA, LAMA, and IC. That is triple drug combination. So that's an important aspect of management here in exacerbation group of patient. Okay, while in a dyspnea group, only LABA or LAMA or LABA or LABA combination. And important thing over here is single inhaler therapy should be considered. A technique should be proper, and non-pharmacological treatment like pulmonary rehabilitation or dyspnea relieving other techniques should be used for the management of COPD in this group of patients. So COPD exacerbation, again, it depends, and the other aspects. What are the other things? The vaccination, pneumococcal vaccine, then Shingrix vaccine, respiratory syncytial virus now will come, COVID-19, all have been included in the management of the smoking cessation. Here, first time they say, Gold says, add pharmacological drugs over here for smoking control, besides only, and not only the counseling, but add pharmacology. The first time they are mentioning use of pharmacological drugs. This is something new. And exacerbation is now defined as all the change in the symptom, worsening of symptom less than 14 days. And then the treatment remains same. Basically, bronchodilator, antibiotics, and corticosteroids. And on the long run basis, we should do the triple drug combination. So this is asthma COPD overlap. The beautifully they say that these are two different diseases together. So if you have symptoms predominantly asthma, we treat like asthma, COPD treat like COPD. If you think there is an overlap or that a mixing is there, then treat like an asthma. That's very important. So in COPD asthma, if you feel there is a together disease happening, then treat like an asthma. So take home messages are very clear. For asthma, diagnosis needs clinical cluster with lung function test or picometer. Formoterol and budesonide is a superior combination. Okay, and for controlling asthma, LABA and ICS, reliever should be combined with always SABA with ICS. That's very important. And for COPD, the importance that there is a concept of age has been come over here for a COPD diagnosis and treatment. Importance of spirometry in COPD diagnosis is redefined, and PRISM and pre-COPD conditions have come. Triple drug combination is appropriate in patient, is always encouraged, especially with a single inhaler, and non-pharmacological interventions need equal emphasis in the pharmacology along with the pharmacological intervention in COPD management. I think these are some new changes. We're hoping that our prescription will change in COPD and asthma management, so patient will have better control of both the diseases. Thank you very much.
Thank you, sir. Excellent deliberation. I've got just one question.
Yes, sir.
Whenever we are taught about COPD, we always recommend doxycycline is generally not included. And if you talk to any doctor, I think there's no doctor is not using doxycycline in his daily practice, whereas they always recommend roflumilast. And my personal experience is that I have tried it just because I come across it theoretically so many times, but I have not found it very impressive. So I would like to have your personal experience regarding roflumilast and doxycycline.
Doxycycline or theophylline are we add. It's not that we cannot add in the, but we have to be very careful when we are using theophylline in asthma, and it is an add-on drug in the you can say the advanced COPD or group E COPD, definitely not in the group 1 and group 2. Okay, and side effects are generally tachycardia and cardiac side effects you have to watch. Roflumilast is being specifically used for a frequent exacerbators. Okay, when there are no eosinophil counts are not high, where we are not supposed to use inhaled steroid. If you are not going to give inhaled steroid, roflumilast can be added. Now the side effects of roflumilast is that people who tolerate roflumilast, they tolerate very well, and people who do not tolerate roflumilast, they will never tolerate. So what are the two side effects which given by roflumilast? One is loose motion. So people who have got constipated abdomen, they will be very happy. And patients who has got a weight loss, the thin people will lose weight very rapidly. So weight loss and loose motions are the two important side effects. You can certainly add those drugs, okay, in the difficult COPD patient. Even not only that, if patient is smoker, you can think about azithromycin after proper monitoring and counseling the patient. So smokers will be azithromycin, non-smoker COPD will be your lofrimist. They have role to play. Thank you.
Thank you so much, sir. So to present Memento and Angavastram to Dr. Prahlad, sir, I would request Dr. VB Singh, sir. On okay. Moving towards our next session, the session of Dr. Rajadhar, sir. I would request Dr. Prashant Chachar, sir, to please speak the biodata of Dr. Rajadhar, sir.
Yeah, so Dr. Rajadhar is a pulmonologist who is, I mean, you know, how do I start? He's a dear friend, and he's a very eminent pulmonologist. He's extremely good in pulmonary medicine. He's a very good teacher, a very good academician, and he is also a very good team leader. So he's at the moment the director and head of the at the CMRI hospital, no, at the Birla Hospital in Kolkata. And Raja, great to see you. Missed you. Yeah, missed. And I was hoping to have a drink with you. But over to you, Raja. Raja is going to speak about the role of artificial intelligence in respiratory medicine. And I think there was a question at the press conference. And I think there's nobody other than Raja there who can do this talk.
Thank you very much, Prashant, for those kind words. Absolutely great to have you introduce me. And a big congratulations to Dr. Pathak and the entire team for having arranged this meeting now for, I don't know, the fifth, sixth year. I have been lucky to be there in person. This time, due to a personal health challenge, I couldn't be there. But congratulations again for arranging the meeting. My talk today was on a topic which is a little different. It was on artificial intelligence. Artificial intelligence has come into vogue in the last 10 odd years, and there's been rapid progress. And during my talk, I'll talk to you about certain facets of artificial intelligence which are applicable to pulmonary medicine. As you all know, artificial intelligence looks at machine learning and then predicting. And it is applicable in things where there is a pattern recognition involved, be that in chest x-rays, CT scans, spirometry, etc. It's pattern recognition which is at the base. I have a lot of my colleagues who feel artificial intelligence is here to replace the human mind. I would like to tell you, and I've done that through the course of my talk, that artificial intelligence is there to help the human being and also help the doctor and also make patient care better. That's what artificial intelligence is all about. It's important for all of us to embrace it, learn about it, and take it in our clinical journey if we have to remain topical. So hopefully, over the next 20 odd minutes, I'd be able to convince you that knowing about pulmonary medicine, knowing about artificial intelligence and its application in pulmonary medicine and other areas is something which is a must. This is a vast field, and I have tried to encapsulate all of it in 20 minutes. I hope you enjoy the talk. And I know Dr. Prashant Hajar there would be more than adept in answering any questions as a part of the talk if they arise. Thank you so much, Dr. Pathak and the rest of the team.
Thank you so much, sir. Video चला रहा है? Dr. Rajadhar had given a small video. For that, we are going to play. Play करो. यहाँ से कर दे, इसको कर दो. पेन ड्राइव यदि कहाँ है?
ये है ना, रुकिए एक मिनट,
थोड़ा सा बढ़ा दो।
एक मिनट रुकिए।
पूरा चलाना
नहीं, बढ़ा दे रहा
प्ले करते
इसे चिल्ला रहेंगे, हमने नहीं बोला है, पेपर में नहीं
is to speak on a topic which is slightly different. I will try and explain to you how artificial intelligence has changed the practice of pulmonary medicine in certain areas of chronic disease. And I'll do that in the next 15 odd minutes. So the world of artificial intelligence really came to the fore when the then chess champion Gary Kasparov took on an IBM supercomputer which was called Deep Blue in a set of 6 games. The first set of games were won in 1996 by Gary Kasparov. However, Deep Blue then met Gary Kasparov in 1997. Then dawned the realization that a supercomputer, an app, could actually perform better than human intelligence, or at least be on par with the very best of human brains that was available. And that, I would argue, was the inception of artificial intelligence. Since the time, over the span of about 25 years, there's various AI-based algorithms that have been applied to medicine. I present to you on this slide a variety of different softwares, different AI-based algorithms, which has been approved by the FDA. The ones that I have circled for you, the ones which I have highlighted for you, are the ones which are related to us in pulmonary medicine. The ones that I have highlighted on this list are till 2019 and hence are from the pre-COVID space. And you can see diagnosis of sleep sleep disorders, chest X-ray analysis, identifying pulmonary embolism are FDA-approved AI-based algorithms in pulmonology space. Since 1991, during the COVID period, the world slowed down. We still got very valuable inputs on AI platforms. I show you a couple of these before I move on to a core pulmonology field. This is one which has been again sanctioned by the FDA back in 2022, which is a single mandibular movement signal which predicts sleep apnea in patients. This is based on home sleep studies where there's a sensor placed underneath the jaw. This transmits raw data onto a cloud-based storage where the analytical pattern gets analyzed. There's lots of raw signals which are then transformed into outputs, and this tells people with a great amount of sensitivity and specificity diagnosis of sleep apnea and the sleep staging therein. It's another AI area which is important. Other one with which I have worked with during the COVID pandemic was a machine generated view of the role of blood glucose levels in the severity in stratifying the severity of COVID-19. And while this is not in the pulmonology space, I've used this because it uses a lot of areas of AI which are relevant all over medicine, but also in pulmonology. So you look at COVID-19 data set, You look at articles which have blood glucose in it, you extract entities, and then the automatic selection of papers looks at not just blood glucose, but its concurrence with hypertension, with metabolic disorders, diabetic ketoacidosis, comorbidities, etc. So, wide variety of areas in that particular space. And it tells us how fasting plasma glucose can predict severity of COVID. I want you to hold on to this thought. This thought where various risk factors in the area of diabetes and their comorbids together give you predictors for a disease process, in this case, COVID-19. Let's now move on to respiratory diseases. And I start off with our bread and butter. I talk about the potential role of AI in score, honeycombing, traction bronchiectasis, and fistral displacement together are important features to quantify, and in some cases, a priori knowledge may not be available or even be correct. It's an assembly of all these factors which help in coming up with predictive scores. The other alternative approach is deep learning, where the computer is fed with information which is random, which is across the board, and you don't pick and choose for the computer as to what you want to teach it. When you provide them with large quantity of annotated data, the computer picks up what's relevant and learns by itself. That, remember, guys, is what is called deep learning. So let's start simple. Let's teach a computer to identify cats and dogs from photographs. Even by visual assessment, you know the top one is a cat and the lower one is a dog. Now change this with pixel data. So pixel data, you see the yellow and the red. This is pixel data. It uses a combination of statistical correlation and probability corresponding to cats or dogs. These are good at picking out subtle differences that matter. So the white wolf and the Samoyed, which look very similar to the eye in front of you, actually the AI tool will pick up that these two are similar and different animals. And then you ignore variations which are important. Both of these, while they look different from different angles, are white wolves at the end of the day. So this inter-observer agreement was looked at for UIP pattern definition in CT in the ATS-ERS criteria. They looked at human assessment. They had 112 thoracic radiologists, and they hardly managed to come up with a clinically acceptable correlation. Their decisions varied across the board. Why is this important? This is important because 50-day mortality with a surgical biopsy today is up to 2%. You might initiate wrong treatment thinking that there's fibrosis in the lung. There's delays in initiating the right treatment for patients. That's why an AI assessment tool helping to tell you, prognosticate for you, is something very important in treating patients with pulmonary fibrosis. I often use this example when talking about AI. It's not that radiologists are stupid. It's HRCT interpretation, which is difficult to the human eye, at least in some cases. So if you look at that figure, you could call it a duck, you could call it a rabbit. It depends on the angle at which you look, and something which is software based would do a much better job at it. Some of the patterns are mixed. There's honeycombing and emphysema in the same CT. There are very subtle basilar changes which might not be visible to you on the CT scanner when you see these scans. Hence, the impact of misdiagnosis is huge. Data shows, and this is BMC Pulmonary Medicine from not so long ago, that radiologists make mistakes in interpretation of CT showing ILD in more than 50% of cases. The 1 year delay for diagnosing ILD is up to 4 years in our country. There's reliance on specialist centers, there's financial burden, there's increased patient burden. This presents an opportunity for automated diagnosis in patients with idiopathic pulmonary fibrosis. So I finish off again with deep light learning in fibrotic lung diseases. I show you Gary Kasparov's picture again. It is not the machine trying to replace the human being. We are not trying to replace radiologists. We are just trying to make their jobs easier. We are trying to make it more precise. I think we have to accept today that AI is here to stay across all branches of medicine, definitely pulmonology. It's better that people like myself embrace it rather than trying to avoid it. In most cases, it will be an adjunct to the human hand rather than being a replacement. Patient care will evolve with this. Patient care would improve, and it will be the AI helping the doctor in trying to manage our patients better. Access to healthcare in remote areas will become better and become more standardized with AI. So, strong message from my side. Think of AI as your friend, learn it, use it in your clinical practice, and I'm sure that 50 years down the line, we can work collaboratively much better without fearing that this is here to replace us. Thank you for listening, and I hope you have a great conference.
So I think that was a very enlightening talk by Rajadhar. Many people had questions on that, and I'm sure that lecture has cleared all these thoughts. I think in the interest of time, I think we can move on to the next topic.
So the next topic for this session is role of pulmonary functions tests in clinical practice. And the speaker will be Dr. S.K. Pathak, who is the organizer of this program. He did his MBBS from GSBM Medical College in 1996 and DCH in pediatrics from the same GSBM.
Yes, sir. 2 minutes, fast करें.
He did his MD in chest medicine from KGMC Lucknow. He did his work experience with ITRC Lucknow and research fellowship in KGMU along with Professor Rajendra Prasad. Presently, Dr. Pathak is running his own setup and he is the medical director and senior consultant with Breathe Easy TB Chest Allergy Care Center, Assi, Varanasi. Over to Dr. Pathak.
Thank you, sir. Thank you for nice introduction. Thanks and good evening to everyone. For a short notice, you have all present here. और हमारे सर गुरुजी भी हैं, डॉक्टर राजेंद्र प्रसाद सर, हमारे कोलिग्स भी हैं. मुझे बहुत अच्छा लग रहा है. वी आर जस्ट गोइंग completing the 11th conclave, the respiratory conclave. The topic is very simple because I want to tell something short, important things about the pulmonary function test. As we know, pulmonary function test to know the lungs function, how it's physically work, because the X-ray test, CT scan, everything will give the anatomical picture, but physiological picture will be by the pulmonary function test. And pulmonary function test especially includes many things. That spirometry is the most common, where the whole body plethysmography, single breath nitrogen washout, DLCO, peak spirometry, pulse oximetry, ABG, exercise testing, CPT. These are the component of pulmonary function test. The component of pulmonary function, maximum inspiratory pressures, physiological testing during sleep or sleep study. And most common diagnostic tools is the spirometry we are using in daily practice. So, sir, spirometry is very important things. It's work like a ECG of lungs. Just we are just knowing the cardiac status ECG, where we just doing the ECG of lungs by the spirometry. The indication of spirometry is generally to rule out the diagnostic purpose as obstructive or restrictive lung disease, screen people to risk of pulmonary diseases, assess the preoperative risk for surgeon is very important. Before any surgery, you have to advise the patient for pulmonary function test, especially to rule out the any respiratory diseases in like COPD, asthma, any lungs diseases, assess the prognosis of the disease, assess the therapeutic interventions, with assist the patient a part of rehabilitation program. It produces survey of the pulmonary diseases, and to follow up the cases many, to monitor the treatment of bronchial asthma, COPD and anything, and evaluation of the impairment of lungs, identification of high risk groups like smokers and serial respiratory, occupational survey, and environmental hazard detection. So indications such as drug exposure related lungs diseases, pre-employment screening is very important for any employment, and physical fitness. We are just doing the spirometry, how lungs is working well. Indication in day-to-day practice to diagnose the bronchial asthma, assessment of severity and monitoring the response of treatment, detection of asymptomatic deterioration of at home, the self-managed patient. Identify the trigger factors, occupational asthma, detection of COPD, evaluation of dyspnea. This is a procedure, something, ATS, some guidelines. We have to use a standard pattern for any spirometry test, because if spirometry doing not well minored, then the report will be false. So in many restrictive patterns and obstructive patterns, there is some parameters be just down and some parameters are just up. So for the restrictive patterns, FBC always down, where the obstructive normal or maybe down, where the FBC always down, usually just down, and the AB1, ABC is normal or low in the obstructive patterns, and TLC always down and normally high in the obstructive patterns. These are some flow curves for spirometries, where the spirometry and the spirometric grading of asthma, just stage 1, stage 2, stage 3, stage 4, we just rate the based upon the predictive value of the A1C, and mild persistent where the predicted value of variability is 20-30%, while stage 3 60 to 80% of predicted value, and variability is 30%, where the severity of persistent asthma less than 60% of predicted value of less than 30%. Avian values is generally less than 1 liter is a major impairment if you measure the spirometry avian value. These are the some graphs presentation how we can identify something graphic presentation after bronchodilator, before bronchodilator, and normal is way. Flow rates of lungs volumes, generally there are various lung volumes measurement, peak spirometry, force spirometry, maximum flow rate, P value, and tidal volume, generally measurement, vital capacity of lungs, and force vital capacity, generally the measurement, and force vital capacity in 1 seconds, residual volume as a measurement in the restrictive lung patterns, where FRC values measurement in restrictive patterns, and total lung capacity measurement. These are the graphic presentation where we are just measuring the lungs volumes, many differences. Predicted normal values, and normal is a normal range is the 90% of the healthy normal population. Indians have lower values compared to the Westerns. North Indians have higher values than South Indians. The predicted value, pre-test requirement is very important. Subject to be stand up high and sitting a posture, stretch, and ideally should be smoking stop before 24 hours, as well to ask the patient to last smoked at cigarette, consuming of alcohol at least 4 hours, and various exercises at least 30 minutes, wearing of tight clothes to avoid it, and eating of substantial meals at least 2 hours prior to test. And this should be performed when the patient is clinically stable and free from any infection. So inhaled bronchodilators generally recommended withholding, short acting 4 to 8 hours, long acting 24 hours, anticoagulant is 6 hours, and oral short acting bronchodilators 6 to 8 hours, and sustained release beta 2 agonist 24 hours, theophylline 24/7, once a daily preparation 48 hours. The subject should be seated at approximately 5 minutes prior to the test, and should remain seated throughout the investigations. Should sit up upright and chair with arms and backrest. The procedures, carefully explain the procedure to patients, and loosen the tight clothings, remove the nose rings, and ensure that he is sitting in erect posture. Apply the nose clip on the patients and remove the loose dentures. The place of lips and teeth tightly around the mouthpiece. The patient should be instructed to breathe in a fully and possible, which he can do. Then to blow out the equipment as hard as fast as possible until the further gas can be exhaled. Must be at least 6 seconds and can be taken after 15 seconds. The patient should perform minimum 3 attempts. At least 3 attempts should be taken for spirometry. The results reported should be at the largest value achieved from the 3 technical acceptable test. The difference between the values should be at least less than 5% or 100 ml. The measurement of slow vital capacity is also many procedures just doing short time. We just cannot explain. Important things is a criteria for acceptable of the any report. Rapid rise of the short and test until the peak flow is reached. The maximum effort maintained throughout the procedure. No sudden cessation of low. Maximum inspiration effort so that the curve is rejoined the point. It's maximal inspiration. At least 3 acceptable reversible attempts should be tried. Error in the measurement is always the leak around the mouthpiece, a poorly coordinated short test, and early termination of flow, and the flow gas, coughing, cough free, and the expiratory effort was the submaximum, unable to obtain. These are some graphic presentation common problem in the flow volumes. The measuring reversibility airflow obstruction, they measure the degree of reversibility flow obstruction performed. This permitted before the 10 to 15 minutes before administration of beta-2 agonist. Beta-2 agonists are generally considered the benchmark for bronchodilator. Bronchodilator response to increase the baseline FB1 after bronchodilator at least 12% or 200 ml. Dose of bronchodilator should be used the 400 microgram salbutamol or both anticholinergics. Repeated test at 10 to 15 minutes, and when they do reversibility test, the high reversibility and exclude the asthma. The contradiction very important. No apparent absolute contradiction, relative contradiction. Hemoptysis always divided in pneumothorax, unstable cardiovascular status, recent myocardial infarction, thoracic abdominal cerebral aneurysm, nausea, vomiting should. They are contradiction. Recent eye surgeries, recent surgery, thoracic abdomen should be avoided. Contradiction. The complication generally syncope, dizziness, pneumothorax, chest pain, coughing, bronchospasm. Infection control measures should be always take care of this. This is the some graphic bronchodilator response. Generally, as I just told previously, the PFT test indicate the risk of the post-operative common. Post for the surgeon is very important. FB1 is less than 2 liters. FB1 less than 40% predicted value. FB1 200 to 12 less than 200 liter per minute. MAB less than 50%. ABG PCO2 is less than more than 45% is a risk factor for the patient for surgery. So take home message for this topic is the PFT is the major physiological diagnostic tools to know about the lung function. Like ECG, by PFT we can diagnose obstructive respiratory disease, screen people of the pulmonary disease, assess the pre-operative assessment. To assess the therapeutic intervention, assess the patient as a part of rehabilitation program, epidemiological survey. So the summary as here very important thing is percentage indicator for pre-operative is very important. If we are just going for any surgery for surgeon, FB1 is very important, PCOT is very important, spirometry is not perfect, then we have to avoid the surgery. Thank you so much. Thank you.
Thank you, Dr. Pathak, for this lucid lecture on spirometry. If anybody has got any question, Dr. Pathak is ready to answer.
Okay, so I would like Dr. Rajin Prasad sir to present bouquet and Anugavastram to Dr. S.K. Pathak sir. I would like chairpersons also. Dr. Rajendra Prasad, sir, to present Angavastran and Memento to Dr. Chairperson, sir. We are running short of time, so we are moving towards our last session. Would like to call for chair Dr. Vivek Nangia, sir, Dr. G.K. Mishra, sir, and Dr. V.P. Singh, sir. Please have a seat, sir. दे दिए सर सर इधर आ जाइए दे दिए बुलाएंगे ना वो लोग बुलाएंगे ना चेयरपर्सन सर ओवर टू यू डॉक्टर वीपी सिंह सर
Hello. I would like to invite Dr. PC Kathuria sir. Topic is allergen immunotherapy in the practice of the allergic asthma. And Dr. PC Kathuria is a senior consultant, Department of Allergy and Asthma, BL Kapoor Hospital, in New Delhi. His 43-year experience in the clinical practice, allergy and asthma, and he is a renowned allergy consultant in the BL Kapoor Hospital, Delhi. Now, Dr. PC Kathuria.
Friends, ladies and gentlemen, regards to all the senior fellows and also regards to Dr. Ansari, who I met after many years. My topic is on allergen immunotherapy in allergic asthma, where we are now. My statement starts with anyone can do skin test, but very few knows how to interpret the skin test sensitization with the history. And the most difficult part in clinical practice of allergy is how to select the allergen for allergen specific immunotherapy. Everything is evolving in this universe. So is the medicine, so is the allergen immunotherapy. Started way back in 1910, the subcutaneous immunotherapy, and 1986, started the sublingual immunotherapy, from evidence-based medicines to the reality-based medicine. 100 years back, it was the skin test only, for which afterwards we used to AIT, allergen immunotherapy. But now in this world of the molecular allergology, we have got a specific purified standardized allergen extracts along with the skin test also. Initially, most of the patients, they were monosensitized. But now at present, we see a lot of the patients are polysensitized, associated with the allergic rhinitis, rhinoconjunctivitis, rhinosinusitis, or food allergy, atopic dermatitis, along with these patients. All over the world, subcutaneous is the first which is being used, except in certain European countries. In India also, we use the subcutaneous allergen immunotherapy rather than the sublingual, as the DCI still has not approved in
if you look at the comparison between this, subcutaneous has a better edge over the sublingual immunotherapy, not only because that it has got a long-lasting effect, but sublingual immunotherapy has certain limitations. Meta-analysis done, subcutaneous immunotherapy is much better than the sublingual immunotherapy. No questions of the efficacy and safety in case of the respiratory allergy and venom allergy, but there are certain question mark in the other, right, food allergy or latex allergy. You see, the guidelines has also accept there is a high efficacy in case of the respiratory allergy as well as but there is a modest efficacy in case of the atopic dermatitis or OAS. Why there is a need of allergen immunotherapy? Because if you look at the 60 to 80% of the patient of asthmatic, they are atopic, allergic, IG mediated, and more than 50% in adult also they are atopic. So these patients, if you look at the causative effect, is the allergens. In every allergen exposure, there is a loss of the lung function. That's why most of these patients, their severity of the disease occurs. So if you treat with these etiological factors, if you detect this, at least you can give the remissions to in due course of the time or disease control. What we get is not only the disease control, disease modification, as well as the disease remission, but also we can prevent the ongoing inflammation, ongoing remodeling in these cases. We have got a 5 parameters which we see that it should be done with this, like the exacerbations, lung functions, ICS withdrawal, symptom scoring, and quality of the life, which we look for once we start with the AIT. Now, if you look at the what is new in this, if you have caught a case of the seasonal allergic rhinitis, seasonal bronchial asthma, either you use subcutaneous immunotherapy or sublingual immunotherapy, there is a hard data, the evidence is A. But if a patient belongs to the perennial allergic bronchial asthma, perennial allergic rhinitis, then the evidence is poor. You have to only go for the subcutaneous immunotherapy. And now the sublingual immunotherapy, which the GINA guidelines or the YAKI guidelines, other guidelines, it is a add-on therapy to control the symptoms, to control the exacerbations, and to increase the quality of the life. But if you have got or these studies, which is the RED, the reality-based studies, then it has found that there is a decrease in the bronchial hyperresponsiveness as well as there is a long-lasting effect, which differs from the rest of the drugs. None of the drugs which is do like this. So there is a complex journey of this allergen immunotherapy. If you look at this, 110 years back, this Dr. Noon published first paper. This is a protocol which is given here that if you start with this updosing as well as then the maintenance dosing, then there is a response is there. But the most of our centers, they are using this protocol. But most of these patients all over the world, hardly 20 to 25% they are on allergen immunotherapy. Reason is behind that there is adverse effects during this journey. There is a poor adherence during this journey. Then now after the 2011, with the advent of the biological, has really paradigm shift towards from conventional immunotherapy to the cluster immunotherapy. So we use at present not only the allergen immunotherapy, but also the biological also. The fundamental difference between these two, that biological they act, but the response lost once you stop it. But the allergen immunotherapy, they have got a long-lasting effect and there is a reduction in the bronchial hyperresponsiveness. So not only it increases the effectiveness, not only it decreases the adverse events, but at the same time there is a extend the allergen immunotherapy even in a partially controlled asthma and has got a steroid sparing effect. So if you use the allergen immunotherapy in a pre-modeling stage, the definition of pre-modeling is there. If the duration is very less than the age of the 10 years, or if there is a patients, those who are a normal lung functions, or children's, then there is a remission in these cases. But if you use the allergen immunotherapy in a state of the chronic inflammation or already the remodeling has started, then the results are only the response is the control of the disease. Remission is not possible. So right patients, right test and the right interpretation is big. If you look at the comorbidities, most of our patients, they are associated with the allergic rhinitis, food allergy, atopic dermatitis. Now these patients, they need special treatment. Why? Because most of these patients, they are polysensitized and the selection is very important. These 7 groups of the allergens, if you know it, these allergens you have to judicially select which patients is there. We treat our patients with the major allergens, not the cross-reacting allergens or the other allergens which has got the incompatibility. So question is there, where we can prevent our allergic asthma? Can we prevent in our children so that it should not go into the ongoing inflammations or chronic remodeling? So we have divided into 3 phases. Can we prevent to primary prevention, where the child is risky, skin test is positive, but there is a patient is asymptomatic, or secondary prevention, where the patient is symptomatic, but the disease is very mild, only the rhinitis with or without intermittent asthma. And third is the tertiary prevention that we look at, but all over the world, it is the secondary prevention. A lot of the voluminous material is there which can reduce the ongoing inflammation if you select your patients in a secondary prevention. But in tertiary prevention, once there is a chronic remodeling, very difficult, only the intensity and the severity can be decreased. But in primary prevention, very little role. Now look at this. What are the primary prevention? Child at a risk phase. Are those children, so those who are asymptomatic? In these patients, is there evidence? 3 studies has been done. It was found that if you give even the sublingual immunotherapy, efficacy is clear. Go already these patients, they doesn't have even the inflammation, only the sensitization. So these patients still we need more study for evidence. Second is the cases of the seasonal allergic rhinitis or seasonal allergic asthma. These are the voluminous of the patients which you can select and do the allergen immunotherapy. Most of these evidence is available. There is a gap study. There is a PET study which has already done. These are the robust study done, and it has confirmed that if you select these patients, at least you can reduce the ongoing inflammation. You can reduce the ongoing remodeling. PET study has been done for 3 years and 7 years follow-up done, and they found that there is a reduction in the bronchial hyperreactivity. And most of these patients, those who took hardly 25%, they get asthma. 70% there is a reduction in there. Another study 2023 has come. It has already confirmed if patient is a pollen immunotherapy, there is a remission. But if there is a patient of the perennial allergen, at least you can decrease the bronchial hyperreactivity. Now, if 20 years follow-up has been done, that allergen immunotherapy decreases the new sensitization. So 14-year studies also has been done long back. If you look at many studies, has confirmed that allergen immunotherapy has got the decrease in the intensity and severity as well as preventing the ongoing inflammation. So ladies and gentlemen, my take-home message is there that if you have got a monosensitized patient, if it children are there and 3-year give, at least you can give remissions to these patients, but you have to test early, treat early, and train the immunity in these patients. Now we're coming to the asthmatic patients. What will you do in your asthmatic patients if the patient is a perennial? Perennial means the patient does not have even the 10 to 15 days in a year in which without LABA and ICS. These patients need now how to differentiate phenotypic and endotypic differentiation. So select these patients. Now the GINA guidelines has come 2017. But before that, we have got a lot of the evidence is there that these patients, they need in step 2, step 3, and step 4 allergen immunotherapy. GINA has given the evidence that if you give tablets only, not the drops of the sublingual immunotherapy. GINA has only looked at the control only, exacerbations, not for the bronchial hyperreactivity. And this is based on the studies. They found that these patients, they were prevented from ongoing from step 1 to step 2 or step 2 to step 3. Or these patients strongly suggest that not only prevent the occurrence of asthma also. 2023 we have found that there is no questions of efficacy in a house dust mite and a grass pollen allergen immunotherapy. But these patients, they need purely selections of the allergen. Now coming to the another guidelines. If you have a patient who is atopic, allergic, IG mediated, you select. Rather than using the high dose of the ICS lava, ICS you make it a medium or the high dose, keep the allergen immunotherapy at the top of there. And if you have got a special case, those who are a house dust mite, these patients should be given even in a partially controlled asthma. But the condition is there that these patients must have a FE1 more than 70% and there should not be any exacerbation for the last 12 months. Why house dust mite is important? If you look at this, 650 million cases of the allergic rhinitis all over the world, 350 million cases of the asthma, 50% of these patients, they are sensitive to only single allergen, and these patients, they need allergen immunotherapy. I will not go into the any further studies because of the time constraints, but just to take home message is there that in those cases, those are tertiary prevention, those who are already well associated with the comorbidities, these patients, they need biological. We need now at present the standard purified product formulations, not the crude extracts which were using for the last many years. And if you use a biological on this, at least you can give the early response, better response, and these patients, they respond early. Now look at the study recently, it has come 2023, subcutaneous immunotherapy with the biological has a much better response. So ladies and gentlemen, these are the cases which we have published that biological and allergen immunotherapy is the talk of the today, not the allergen immunotherapy itself. It is safe and effective and give more rapid relief. And even the built-up dose has been decreased up to the 6 weeks, which was 7.5 months before. So biological is given. A lot of the studies are going on. Already omalizumab for the last 20 years we have with the omalizumab with us. Now the study on the anti-IL-4 alpha unit is being done, and the study also is going on the TSLP. Let us see the outlook is better and the future is bright if you select the judicious selection of the allergen. With this, thank you very much for your kind attention. Okay,
Thank you very much, sir. I would request Dr. A.K. Singh, sir, to present Momento and Angavastram to Dr. P.C. Katoria, sir. Dr. J.K. Mishra, sir. Sir, Momento and Angavastram. Now I would request Dr. Rajendra Prasad, sir. Sir. Dr. Vivek Nagia, sir. वो पढ़िए.
May I now request Dr. Rajendra Prasad, please come and address us on the clinical pulse in respiratory allergy. I don't think anybody really needs to, listen about him. He is a very well-known figure, a stalwart in pulmonary medicine who's probably taught each and every pulmonologist of the country at some stage or the other, whether in classrooms or in lecture theater halls or in the conferences. We've all always learned from him and always looked upon him. He's the Director Medical Education, Professor Respiratory Medicine at ERA's Lucknow Medical College and Hospital, Vice Chair of the National Task Force India, and Emeritus Professor, National Academy of Medicine, Medical Sciences, Emeritus Professor for Indian Medical Association and Convener of the State Chapter for the National Academy of Medical Sciences for UP. Sir.
My slides are coming. Thank you, Nagia, for very, I must say, elaborate introduction. देखो इंटरेस्टिंग केस होगा So this is the last lecture. I think you people are also tired, and including me. So I'll try to be very brief. And I usually nowadays start my lecture with some of the sayings, and I'll start my lecture with this: that better than 1,000 days of diligent study is one day with great teacher. I'm not saying that I am a great teacher. Since Dr. Ansari is sitting here, who has been my senior during my PG days, so I'm saying this for my mentor, Professor B.K. Khanna. And there are many more. At least we are three sitting in this audience I can know who has been mentored by Professor B.K. Khanna, Ansari ji, and myself and Dr. Katuria. Very hard taskmaster. And these are my institutes. I'll not skip. So when Pathak asked me to speak something about interesting cases of respiratory allergy, I was very busy those days. Then I searched some of the cases which I treated in my lifetime, and I'm going to share with this. This is a very young old boy, student who was studying in a convent school, came with complaints of excessive sneezing since 2 months. His father gave history of sudden bouts of sneezing and mostly during day, but no sneezing in the night after patient sleeps. During day he has all 12 hours sneezing. So they had visited various doctors, and the teacher I referred that he has a foreign body in his, the same teacher referred this young guy to me for allergy testing. That why he is sneezing for last so many years. So he also visited ENT surgeons, all investigated, and nothing was found. So ultimately referred to me for allergy testing actually. Then I did examine, took history in detail. I could not find anything anywhere, either in the nose or in the chest. And X-ray picture, CT-PNS, spirometry, I did normal limits. So what he was given symptom, what to test that really is allergic or not. So I gave broadest spectrum anti-allergic, whatever is possible, including steroids, for about 7 to 10 days to test, because my initial impression was he's not having, he's creating this for something. So, but after 8 days, he came in my clinic again, and I just heard that he is sneezing. So he was observed during OPD follow-up that the child was not sneezing when he was engaged in some activity. As I said, he was a convent. He was studying in a convent school, about 7th standard. So I asked him, मैंने कहा भाई तुम ऐसा कर 1 से 20 तक गिनती, तो हिंदी जरा कम आती है अंग्रेजी स्कूल वालों को. हमने कहा हिंदी में गिन और 20 से शुरू कर और 1 तक आ, रिवर्स आर्डर में. तो उसने 20 से लेके 15 तक तो गिन दिया. 15-16 के बाद जब देखा कि उसका दिमाग लग गया वहां सोचने में कि 15 के बाद क्या आएगा, तो ही स्टॉप स्नीजिंग. एंड हिज फादर वाज अ हार्ट पेशेंट. और फादर क्या कहता था, मैं आपको स्टेटमेंट सुनाऊं. वो कहता था, डॉक्टर साहब इसकी एक छींक मेरे दिल पे जा रही है. मेरे दिल पे जा रही, तो साहब इसको आप कुछ करो. व्हाट इज दिस? आपके गुरु भी ना समझ पाए. मैंने कहा भाई. Then while counting, he stopped sneezing in front of me, in front of his father. Father was standing beside him. मेरा मन तो यही कर रहा था इसको एक लपड़ तेज मारे. लेकिन मैं हिम्मत नहीं कर पा रहा था. लेकिन to your surprise, his father, because father was also very educated, So he understood that he is imitating, he is doing malingering. So he slapped Allah. A very big slap he gave, and वहीं उसकी छींक बंद हो गई. और फिर हमने उसको पूछते रहते थे, भाई कभी आई दोबारा? बोले साहब कभी नहीं आई. So what I'm trying to say, sometime in clinical practice, we do such type of, I hope in every clinical practice, we see such type of patient. Then another patient, he was about 22-year-old male, again complaints of breathlessness, presented as asthma. But he had streaking also. Somebody wrote him anti-TB drug also. I don't know with this X-ray. I was talking regarding the X-ray. However, we find that there are, if there are laser pointer. So with these shadows, some doctor has prescribed anti-TB drug. That's very common in this state. Without and then when he received 6 months of all four followed by 3 drugs, you see lesion has drastically increased. If these two X-rays are shown to even me without anything in history, I would also say it is MDR TB. So he was diagnosed as, he was suspected as MDR TB because you can compare these two X-rays, and so he was referred to me. Rather, doctor wrote treatment for MDR TB in those days. But he was very smart. उन्होंने कहा एक बार यार डॉक्टर साहब से पूछो कि MDR की टीबी की दवाई खाएं कि नहीं खाएं. Then what I did, when it came, I took history, since there was history of asthma-like presentation. So first thing I did was sputum examination. It was negative. With such an extensive lesion, if sputum is negative, it is telling something. Mantoux test was 13. हम कहते हैं ना IGRA, Mantoux, gold, platinum, so many things. They are nothing. They just tell you that person is infected. तो उसका कोई मतलब नहीं था. In TLC, if you see the pointer was eosinophil was high. So that prompted me to investigate him further. And in further investigation, we did skin tests. It was positive to Aspergillus antigen, even type 1. In those days, we used to type 3 reaction also. And then CT picture are very typical of central bronchiectasis in those days, we used to say. And this picture was very typical of central bronchiectasis. And finally, even total IG against Aspergillus fungus and IgG, all were positive. This was a classical presentation. If you see, it was diagnosed as allergic bronchopulmonary. So this is not very uncommon disease, in our day-to-day clinical practice. We see a lot of cases, and you see that what 6 months of ATT could not do it. A course of steroid, because treatment of ABP is essentially steroid, oral steroids, and so had made all difference in about 6 weeks time. So that is the another case. I'll just quickly scan through. He was again 20-year male. He came to me in 80s. He is still alive and following him up. So about 45 years. So he has breathlessness for 10 years. When he presented to me, along with little hemoptysis, and you see the X-ray picture, look like consolidation, disappearing after about 6 weeks. That it has changed its place. Now it has come into left upper zone, left middle zone, right middle zone. You see all these shadows are fleeting. And this is one of the typical, now it has moved to the left lower zone. And so I just said it was probably pneumonia is walking in every, and this was ultimately diagnosed as, this is the one patient who taught me ABP, because I'm seeing this patient from 1977 onwards. So about 50 years hone wala hai ab. but luckily he's alive. So it's not very fatal disease, provided you manage them well. And it was all the investigations were positive for ABP. Although those days these IG, specific IG, they were not very common to find out, but on a research protocol we managed to done. And these days we used to do bronchography. So this was central bronchiectasis, very typical picture of central bronchiectasis is visible. And we catch hold of him in 2007. Even CT those days was not available in KGMC. So in 2007, we catch hold of him and we got CT thorax done, and typical central bronchiectasis picture were available. So they are all diagnostic criteria. If you read that diagnostic, and these are the few other pictures of ABP, and there's a mucus plugging there, what you call now a mucus ABPA MP, and then sometimes it's present like a mass-like structure. Again, this was a case of an ABPA, central bronchiectasis, we see, and last case, I think I'll go. अभी investigation की कोई बात कर रहा था. I saw this man about a month back. You see the CT picture, typical of ABPA. CT picture was typical of mucus plugging, but the investigation has shown otherwise. They have not shown, in the first say, it says that IG was raised, but specific IgN were not raised, and further on next investigation from next lab. So even labs vary in there, what I'm trying to say. So you have to be very careful. And it was diagnosed as ABPA ham, and this lady presented with collapse. तो कोलैप्स में लोगों ने फिर कहा ये टीबी हो गई इसको. यंग लेडी टीचर थी, तो मैंने कहा उससे पूछा, हिस्ट्री डिटेल में पूछा, तो हिस्ट्री में पता लगा कि पहले उसका अस्थमा का हो चुका है, उसका एक पुरानी जो है यूसनोफिल काउंट था 15% का. That prompted me to think, and again this collapse was because of mucus plugging, and it was diagnosed as case of ABPA. So what I'm trying to say that ABPA, it's not very rare disease. Even we did a study and we could find in the state of Uttar Pradesh, it is around tune of about 7% in one of our study when we have screened about 244 asthma patients. And these are the diagnostic criteria which is available in any book now, and all the criteria in most of the cases has met, and ISAM criteria has come recently, even modified ISAM has come currently. So what I'm trying to give, and there are many types of ABPA now described, latest guideline available in ERJ 24 by Chandigarh group. They have defined ABPA, many types of ABPA. B, MP means mucus plugging, HAM, high attenuated mucus, and CRF, other findings were there. So this is all. So my take home message with these interesting cases, which were mimicking like allergic patients, is that every patient today, what this 24 guideline, and we are also practicing that every patient of asthma must be screened for Aspergillus sensitization first, that you can do by doing specific IG, against Aspergillus fumigators, or by doing a skin test. This is possible now everywhere. And if you find this, then try to find out ABPA also. By ABPA, you have to do specific IgE against Aspergillus, and then CT pictures are very, very typical. So what I say finally, that when I teach that any patient with bronchial asthma should undergo a skin test or this, and final message is asthma. If I teach like this, if any asthma patient, you have some pulmonary shadow, and simply TLC, DLC may show eosinophil count between 10%
more than 10%, you must suspect this condition. These things are little bit changing. In eosinophil is more than 500 is taken as Ig is also level has reduced. So only take home message with this presentation that any asthma patient had some shadow or chronic asthma patient, always try to think about this condition. First, the sensitization will occur and then ABPA will happen. With this, thank you very much. We have many books and meetings. I do have to go. And thank you very much. If you have any question, I love to answer. मैं पाठक के सारे दो लाइन बोलना चाहता था। पाठक जब पढ़ते थे तो इतने मोटे नहीं थे। अभी ये बहुत इन्होंने वेट गेन कर लिया। आई विल सजेस्ट हिम and I must appreciate Dr. Pathak that he asked me in 2014 when he started this कि सर क्या करूं कि ना। हमने कहा जरूर करो। This is the area. In those days the pulmonary medicine was not very, अभी भी बहुत अच्छा नहीं है मैं तो कहूंगा, but please do it. So I am very happy that he is regularly doing it, and probably I have come in every conference. So thank you, Dr. Pathak, for remembering me, and thank you very much.
Thank you, sir. Now I would request Dr. H.S. Ansari, sir, to present Memento and Angavastram to Dr. Rajin Prasad, sir. I would request Dr. S.K. Pathak, sir, to present Angavastram and Memento to our chairperson.
दीपक थोड़ा बैठ जाओगे? दीपक उनको उनके पास कई साल जो है व्यर्थ रहे लगा तो
Now I would request Dr. Rajin Prasad, sir. Actually, we have our entire team of Respiratory Conclave Conference. So I would request Dr. Rajin Prasad, sir, to have to give Memento and Angavastram to our entire team. सब कोई आ जाइए, ठीक है? All the pharma colleagues, you are requested to please come on the dais.
हेलो, थैंक्स एवरीवन। हमारे स्पीकर्स और फैकल्टीज जितने भी हैं उनको मैं धन्यवाद देना चाहूँगा। हमारी टीम है जो इसके लिए लगातार मेहनत की और 2 महीने से लगातार हम लोग मेहनत कर रहे थे, एक सक्सेसफुल प्रोग्राम कर रहे हैं। तो हम इस रिस्पेक्टरी कॉन्क्लेव में हमारे अपने गेस्ट को धन्यवाद देना चाहूंगा, हमारे फार्मा टीम को भी धन्यवाद देना चाहूंगा, हमारे जो स्पॉन्सर्ड हैं उनको भी धन्यवाद देना चाहूंगा, हमारी जो टीम है ब्रिथी जी की उनको भी धन्यवाद देना चाहूंगा। उन्होंने अच्छे लगातार मेहनत की जिससे एक सक्सेसफुल प्रोग्राम हुआ। मैं चाहूंगा इनको अनपसंद देकर सम्मानित किया जाए। थैंक यू।
तो लगा लो ना, दिखाइए अब क्या करोगे? आप क्या क्लोज कर रही बताओ? टीम आ जाइए इधर पूछ रहे इधर अरे यार नहीं एक एक करके आइए तो अच्छा ये करके आइए अपने इंजीनियर खड़े होंगे कुछ करना है कुछ करो जनता को खरीदी बेचारे कॉर्पोरेट पाई कोई इधर घूमिए इधर घूमिए सब हो गया ये हो गया और चला मैं फोटो खींच यार उसको वही पाया मैं क्या बात
बस दो घंटे गाइडेंस के लिए देना पड़ेगा।
ऑन कर दिया ऑन कर
स्वप्निल स्वप्निल
हमारे स्टूडेंट
हाँ हाँ मुझे पता
उधर सामने
एक मिनट वैसे भी जगह छूट गया पहले इनको भी हाँ
अच्छा
एक पहले
ठीक है आइए सर हमको बनाया सर आइए थैंक यू सर हाँ सर सब लोग आ जाइए एक साथ फोटोग्राफ्स ले लीजिए प्लीज सब लोग बैठ जाए बैठ जाए बैठ जाए और सर लगे सर सामने आ जाइए सर फोटोग्राफ सर अच्छा बैठ जाओ सब लोग बैठ जाओ भाई बैठ जाओ बैठ जाओ सर थोड़ा सा बोल रहे हैं, but thanks so much.
मैं जैसा फिर मैं कह रहा हूं कि मैं डॉक्टर पाठक और उनके पूरी इंटायर टीम को बधाई देना चाहता हूं कि पिछले 14 सालों से 10 सालों से ये 11वें है, ये सक्सेसफुल जो है वो ये कॉन्फ्रेंस कर रहे हैं और मैं सबको बधाई देना चाहता हूं और मैं आशा करता हूं ये फ्यूचर में इस तरह के कॉन्फ्रेंसेस करते रहेंगे और कम से कम कॉन्फ्रेंस का एडवांटेज ये होता है, ये पूर्वी जिलों में रेस्पिरेटरी डिजीज का वैसे भी अवेयरनेस बहुत कम थी और मैंने देखा है 10 सालों में इन्होंने बहुत बढ़ाया है, आशा है ये बढ़ाते रहेंगे। धन्यवाद।
थैंक यू सर, थैंक यू सर। डॉक्टर विवेक ने सर सर
मैं डॉक्टर पाठक और उनकी पूरी टीम का आभार व्यक्त करना चाहता हूं कि एक इतना बढ़िया इन्होंने कॉन्फ्रेंस होल्ड करी है यहाँ पे वाराणसी में। आज इतने सब लोगों को इकट्ठा किया है इन्होंने, ये कोई आसान बात नहीं होती है। हम लोग दूर दूर से इंडिया के डिफरेंट कॉर्नर से लोगों को बुलाया है इन्होंने और एक बहुत ही अच्छा शो पुट अप किया। इतनी अटेंडेंस होना, कंटेंट जो था मैं कहूंगा बहुत ही रिच एंड अपडेटेड कंटेंट था कॉन्फ्रेंस का। एंड आई एम श्योर इनको मैं आगे बेस्ट विशेस देना चाहूंगा कि आगे भी करते रहें और इसको आगे बढ़ाएं।
मेंटर कैसे होगा? बड़ा वाला बड़ा वाला कब लेके आना है? सारी टीम को एक साथ ज्वाइन कर दो। कल टीम इंडिया को आई है, आज इधर
डीजे कल रोहित शर्मा लिए थे आज। हाँ बोलो भाई। ये लो भैया।
थोड़ा सा आप लोग छोड़े नहीं
Thank you very much to everyone for your valuable time. डिनर सबका रेस्टोरेंट में है, फुल हाउस में. थैंक यू वेरी मच.